Assalamu alaikum everyone. I hope you're all doing well, inshallah. For those of you who don't know me, my name is Mohammed Alfuwais. I am a fourth year medical student. Inshallah, for today, we're going to start the Endo-Repro crash course. This session today will be on endocrine. The session on Monday, inshallah, will be on reproductive. Now, before I begin, I wanted to just thank you guys for voting me as the best tutor for this year for you guys. It means a lot, and inshallah, I could teach you guys again this year and maybe sometimes next year. Without further ado, this session will be just like the GIT crash course in terms of I will be covering everything, okay, in this block, with emphasis this time on pathology and diagnosis in clinical. Because in clinical endo, the most important thing is you know how to diagnose these diseases and recognize these diseases. So I will begin now, and just like my sessions, I want it to be interactive. I will teach you guys certain things, and then you guys answer me when I ask you guys stuff about the diseases and the treatments. So the first thing we're going to talk about is the pituitary gland. So just a brief introduction to the anatomy, physiology, histology, and so on. The pituitary gland is a small little gland sitting on the base of the skull. It's sitting on this depression on the skull called the sella turcica. Now, the pituitary has two lobes, okay, two main one, which is the anterior pituitary, which is a majority of it, and then the posterior pituitary, which is a very small. Now, there is an intermediate part of it, but it's not important. Now, in terms of its anatomy, what's very important is these two things. Firstly, is its relationship to this sinus, okay, which is the sphenoid sinus. Why is this important is if you're doing any surgical procedure of the pituitary, you'd go through the nose into the sphenoid sinus, which is called transsphenoidal approach, okay? And this is how we do surgeries for the pituitary gland. Now, other than that, it's close relationships to everything else. Okay, what is close to the pituitary gland? The most important structure is this, which is the optic chiasm, which is a decussation of the optic tracts. If you have a pituitary adenoma or a pituitary carcinoma or a mass in the pituitary that's very large, it can cause compression to the chiasm, which leads to what? What signs on visual? What visual signs? Bitemporal hemianopia. Excellent. Good. Okay. And headache as well, right? Because of increased intracranial pressure. But the bitemporal hemianopia is very important feature. Now, another thing that's very crucial is the cavernous sinus. Now, around the pituitary is a cavernous sinus, which has different nerves. The nerves are all the nerves that control the eye movements, plus the first branch of the trigeminal nerve. The whole point of this is if the pituitary gland increases even more, it can cause different ophthalmoplegias. It can cause oculomotor paralysis or defects or whatever, trochlear nerve or abducens nerve pulses. Okay, that's the whole point of this. Now, the most important imaging modality for the pituitary gland is an MRI. Okay, similar to why we use brain MRI is because it's the best to visualize neural structures. Okay, now for the pituitary, you can see that this is the sphenoid sinus, and then over here is the pituitary. This is the anterior, and this over here is posterior. Now you notice how the posterior pituitary is very bright. Why is it bright? Which hormone is causing it to be bright? ADH, excellent. This is very important to remember that it is bright because of ADH, okay? And we'll get to the clinical implications of this later on, but that's pretty much it. If you have loss of this white spot, this is a clue for a certain diagnosis, okay? But anyways, that's pretty much it. Now, in terms of a histology of pituitary gland, you have many different types of cells that's in the pituitary. Three main types based on the color. Then you have many types based on the hormone they secrete. So this is mostly in the anterior pituitary, but you have three different types. The eosinophils, right, the ones that are colored red, okay? the basophilic cells, which are blue cells, and then you have the white cells, which are the chromophores. Okay. Now, from this, if you want to know what cell is secreting what, you need to stain it, which is with immunohistochemical staining. In this case, we're using growth hormone to target growth hormone secreting cells. Okay. So, which is how we diagnose, okay, if someone has a pituitary adenoma, that's secreting growth hormone by any means. We never usually do biopsy. But if we do biopsy and we take the sample, if we want to know if this is actually growth hormone secreting, we do immunohistochemical staining, which tells us that it's secreting growth hormone. Okay. That's pretty much it. Now, the hormones that's secreted from the pituitary. There are six total hormones that's secreted by the pituitary, four by the anterior pituitary and two by the posterior pituitary gland. Now for the four, you have TSH, ACTH, LH, FSH. From the posterior, you have ADH and one more, which is oxytocin. Keep in mind all of these hormones because we're going to talk about them over and over and over again in this entire crash course. Now, you have this first patient, and the first diagnosis I want you guys to make. You have a 30-year-old patient, a female, comes to you with recurrent headaches that is not resolving. Okay. You do visual testing and then you see that they have loss of peripheral vision from both sides, or the temporal vision on both sides. Okay. What do you suspect the patient might have based on these signs and this imaging? Pituitary adenoma. Good. Now, in this case, a pituitary adenoma, is it secreting anything so far? And we don't really know. Okay. There are other signs and features which we'll get to later, but this is the main sign of a pituitary adenoma. Another further sign, as I mentioned, is if it causes any ophthalmoplegia, which is cranial nerve 3, 4, and 6. If it damages any of them, they'll tell you, oh, I can't see it, or I can't turn my eye a certain way. Okay. So this is a pituitary adenoma. Now, what is the most common hormone secreted by pituitary adenoma? Prolactinoma. Good. What is the second most type of adenoma? Okay. Growth hormone or null. Exactly. Good. So null secreting, which is it's not secreting anything. Okay. So it's just causing, exactly. Non-secretory is the second most common, then the growth hormone. The non-secretory adenoma, in this case, it's not secreting anything. However, it's causing the headache, the bitemporal hemianopia. Now, if you have a combination of two hormones that the adenoma is secreting, which combination is the most common combination? It's secreting two hormones. Exactly. Growth hormone and prolactin. These two combined is the most common combination, if there is. Now, for percentages, as I mentioned, you have prolactinoma as the most common. The second most common is non-functioning. Then you have the growth hormone secreting adenoma. The most common combination is this, which is the growth hormone and prolactin. This is the most important thing. Now, gonadotropic, ACTH, TSH secreting adenomas are very rare. From these, we'll talk about this and this slightly later on. Okay. Now, same patient that you see here. What's the diagnosis? Same exact presentation that I already mentioned. Headache, bitemporal hemianopia. They have prolactinoma. They have a pituitary adenoma. Tamam. Now, remember when I showed you histology before, is that it has many different types of cells or different colors of cells. See here, it's a uniform arrangement of cells of the same color, basically, pretty much, because it's secreting one type of hormone. Okay. So this is a pituitary adenoma. Now, there are certain genes that's associated with an aggressive form of adenoma. What are those genes? List them out for me. BRAF, okay. Cyclin D1, okay. Just one more. Okay, perfect. Okay. So you have overexpression of cyclin D1, mutations of p53, and an epigenetic silencing of the retinoblastoma gene. Now, which one is associated with rare carcinomas? There's one more. HRAS, perfect. Memorize genes in this block, guys. These genes are very important. Now, the same exact patient, you take further history. They have headaches and bitemporal hemianopia. Now, they are 30 years old and they're a female. So they're going to complain to you that they have low libido, they have amenorrhea, okay, and abnormal menstrual cycles, and they have galactorrhea. What is the differential diagnosis that you have? Prolactinoma. Excellent. Now you take biopsy and you do immunohistochemical staining, and you could stain it when it turns out to be a prolactinoma. Okay. Very importantly, do males present the same as a premenopausal female? I'm asking you guys this question. No, exactly. Why is that so? The whole, gonadotropic effect, maybe. Low libido, low sex drive, yes, maybe. However, the galactorrhea won't happen unless they have gynecomastia or breast tissue. Okay. Uh, Other than that, it won't happen. Same thing can be said for a postmenopausal woman. Okay. In this case, a postmenopausal woman, they are amenorrheic because of, anovulation. Okay. So in this case, they won't complain to you of, oh, my menstrual cycles are irregular, for example. Okay. So they will come to you with signs and symptoms of mass effect. Okay. So headache, bitemporal hemianopia, and then maybe low libido and low sex drive. Now, why in patients with prolactinoma, they have low libido and low sex drive? Why? And amenorrhea in premenopausal women. Decrease GnRH. That's the main mechanism. Excellent. So prolactin will inhibit GnRH, which will inhibit LH and FSH. Okay. And this will cause the low sex drive, low libido, and the amenorrheic effect and ovulation. Okay. Now, same patient over here. What do they have? We already diagnosed it. Is a prolactinoma. Now, will prolactinoma look like this most commonly or this? One or two? I want to see if you guys know this. One, which is the less dense. Okay, you see all these spots. If it's highly dense, it's less common. It's usually low density. Okay, so this is prolactinoma. Now, how do you diagnose prolactinoma? First, lab tests. What lab tests do you want to do? For a patient with prolactinoma, what would you want to do? Prolactin levels, okay, which will be usually elevated. Now, how much is it going to be elevated? If this patient has mass effect, okay, which is the headache, it's going to be above 200, which is what we call a macroadenoma, okay? If it's a microadenoma, how much will the prolactin level be? Less than 200. Good. Excellent. Now, other lab tests that you guys may do, which is more associated with repro, when we get to it, is you might do LH, FSH, and all the reproductive hormones that we'll talk about in repro, inshallah. So these are the lab investigations, and then you order a pituitary MRI, and you see, okay, they have an adenoma. Now, management-wise, what is the first-line management of prolactinoma? Is it drugs or surgery? Drugs, good. So you start them with dopamine agonist. What is the best dopamine agonist that you can give to patients with prolactinoma? Cabergoline. Good. So the best dopamine agonist that you can give is cabergoline. The other one is bromocriptine. However, cabergoline is better tolerated in patients, less side effects, and so on. So you better give cabergoline. If this patient, okay, you gave them cabergoline, you follow them up, it doesn't work, then you might go to exactly, and decreases the size of the adenoma, and you need to follow them up. You check pituitary MRI level or MRI to check the size of the prolactinoma, and you also do periodic prolactin levels, okay, to check the decrease in prolactin. If this doesn't work, you might do surgical later on. The very important concept that I want you to know about the management of pituitary adenomas is all of them, the first line is surgery, all of them, except prolactinoma. The first line is drugs, cabergoline, okay? So that's the most important concept with prolactinoma. And we mentioned all of this. Now, same patient, or different patient, same headache, bitemporal hemianopia, and has all these features. What's the diagnosis that you're suspecting? Acromegaly. Good. Which is due to growth hormone excess. Okay, good. Growth hormone secreting tumor. Now, is this mostly in adults or in children? Acromegaly. Adults. Good. Excellent. Now, if you guys don't get pictures, what's very important is how they describe acromegaly. First of all, coarse facial features, very protrudent jaw, okay, large forehead, and it comes forward a bit, okay. And the most important sign in these patients, or how they describe it to you, is, oh, I can't fit my, for example, gloves on. I can't fit my shoes. I had to increase shoe size very recently, or I can't fit my ring in my finger, for example. And they will show up to you with sweating. They might have diabetes and hyperglycemia and so on. Another sign that you might see is increased thickness of the heel pad. This is not an important sign, and you usually never do this and never do an X-ray of the foot for these patients. However, it's a sign you might see. Okay, so this is acromegaly. Now, for patients with acromegaly, what is the first lab test that you ask for? IGF, good. Insulin growth factor, insulin-like growth factor. Will it be elevated or decrease in patients with acromegaly? High, good. Okay, it's going to be high in patients with acromegaly. So after you guys have ordered IGF, which is what you correctly said, then you do oral glucose tolerance test with growth hormone level. Usually, when you give an OGTT, it will suppress growth hormone secretion. So if it's suppressed, then you're gonna rule out acromegaly. It's done, okay? However, if it's not suppressed inadequately, then you order pituitary MRI, then you'll see the mass from there, okay? If it's normal pituitary MRI, then you might look for other causes of growth hormone secretion, which could be perineoplastic, and it's not important that you guys know this step over here, okay? Now, with patients with growth hormone secreting pituitary adenoma, what's the first line management? What will you do to remove this? Surgery, okay? Transsphenoidal approach, you remove the growth hormone secreting tumor. Now, next diagnosis. Same patient, headache, bitemporal hemianopia. Comes to you with, they've been complaining that they have become more obese. Their face is swollen and very puffy, okay? They complain to you of these scratch marks or these scars in the abdomen. What are you guys suspecting? Cushing's, firstly, it's Cushing syndrome. Let's just diagnose this as Cushing syndrome first, okay? Which is due to a high cortisol. Now, I mentioned in the beginning in this scenario that they have bitemporal hemianopia, they have headaches, so someone mentioned Cushing's disease, which is correct. However, you need to do labs to diagnosis. Now, you have other signs of Cushing syndrome that you might see, such as hypertension, a buffalo-shaped or a camel hump neck in the back, and a lot of other stuff, poor wound healing, osteoporosis, all these things. Okay. Then you want to diagnose these patients with Cushing syndrome first. What is the first line screening test that you do? There's three, and I want you guys to mention all of them. Dexamethasone, first of all. Is it low dose or high dose dexamethasone in the screening? Low dose, good. What's the second test? Late night salivary cortisol, good. And one more, 24-hour cortisol, good. Perfect. Okay. So yeah, midnight salivary cortisol, 24-hour urine free cortisol, and dexamethasone suppression test, which should be low dose dexamethasone in this case. Now I'll tell you guys lab values or just dexamethasone, low dose dexamethasone did not suppress the cortisol levels, midnight salivary cortisol, which is high, and 24 urinary free cortisol is high. What's your diagnosis in this patient? Cushing syndrome. Okay. Now, what lab test do you want to order next? ACTH. Why? Good. So ACTH, you want to differentiate it. Either they're ACTH dependent versus ACTH independent. Okay. So if they're ACTH dependent, there's something in the body that's secreting ACTH that's going to the adrenal glands that's causing cortisol secretion. Okay. There's two sources of this, either ectopic or from the pituitary gland. We're going to talk about this in more detail later. However, if the source of ACTH is from the pituitary gland that's causing the Cushing syndrome, what do we call this disease? Cushing's disease. Okay, excellent. So this is pretty much Cushing's disease in terms of the pituitary gland. We'll talk about Cushing syndrome and all its types and treatments and everything when we get to the adrenal glands. Now, something else in the pituitary gland, we mentioned the hyperpituitarism, which is everything that happens when there's high secretion of the hormones. What happens if it's the opposite? It's called hypopituitarism. Now, someone who has a pituitary adenoma can present with hypopituitarism. How? Through mass effect. The pituitary adenoma is increasing in size. It's basically damaging the surrounding tissue and surrounding cells. So this can cause hypopituitarism, which is a decrease in the hormones of any of the hormones. Okay. Now you have prolactin deficiency, which is very rare. We're not going to talk about this. Growth hormone deficiency. And very importantly, in children, will cause what? It's based on their size. Dwarfism. Good. Okay, dwarfism. Then you have hypothyroidism, which we'll talk about later, secondary adrenal insufficiency because of low ACTH, and hypogonadotropic hypogonadism. They will have low amount of LH and FSH, which will cause low amount of testosterone, low estrogen, low everything else, okay? Now, important entities to cause hypopituitarism or important causes of hypopituitarism. Number one, as I mentioned, is pituitary adenoma. Okay. Number two could be radiation, could be trauma to the area. Any other mass in the area, and we'll talk about a few of these masses later on. Could be congenital defects. Okay, and we'll talk about one syndrome later on. And then two other important causes. Number one, you have a female who just gave birth and had massive postpartum hemorrhage. Comes to you later on or very rapidly with hypotension, with constipation, dry skin, poor lactation or failure to lactate. Okay. Signs and symptoms of hypothyroidism. What does she have? Sheehan syndrome. Good. Why do they have Sheehan syndrome? Why do patients present like this, and why do they even have it? Is what happens during pregnancy is you're slowly priming the breast for lactation, which is due to prolactin, for example. Prolactin is one of those hormones that will prime the breast for lactation. So because of this, during pregnancy, the pituitary gland will slowly increase in size. Now, this is all normal and it'll go away. Once they give birth, it'll go away slowly because the prolactin levels will slowly decrease over time. Now, very importantly is what happens if they have an abnormal bleeding. Okay, heavy bleeding after they give birth. The pituitary gland, when it's increasing in size, its blood supply is relatively less. Okay, it can't basically compensate for the increased gland. So if you have bleeding that causes hypotension, this will remove that blood from the pituitary gland. So the pituitary won't get any blood anymore, or sufficient blood. So it's going to go into infarction, ischemia, and so on. This is Sheehan syndrome. That's why it causes hypopituitarism. The other cause of hypopituitarism that I want you to know is apoplexy. Someone mentioned it in chat. How does apoplexy present? Is a patient who already has a pituitary adenoma. Now, with adenoma, with cancers, typically, they go through neovascularization. They're synthesizing blood vessels. Now, with apoplexy, is these blood vessels are very leaky. So you have an acute hemorrhage of the pituitary gland, hemorrhage, bleeding. This can cause apoplexy. Sheehan is ischemia or infarction. Apoplexy is hemorrhage of the pituitary gland. These two can cause hypopituitarism. Apoplexy is emergency because of mass effect, okay? Can cause increased intracranial pressure, and if you remember from neuro, what does that do? Herniation, and the patient will die on the table, okay? So that's why you need to treat it emergently with surgery. Okay, Sheehan, you control the first thing is the abnormal uterine bleeding. You control that. And we'll talk about abnormal uterine bleeding in the next part of this crash course. So same patient over here, already pre-existing pituitary adenoma, comes to you with a massive headache, severe headache, some visual disturbances, confusion. What do they have? Apoplexy. This bright spot over here, this is the hemorrhage, and it's going down into the sella turcica. Okay, this bright spot or bright mass over here is an indication of active hemorrhage. Okay, so that's how you know that this is apoplexy. Now, for syndromes causing hypopituitarism, you have let's just say, a 14-year-old male who comes to you with difficulty smelling, okay, and poor and delayed puberty, has not reached puberty yet. What do you suspect? Kalman syndrome. Good. The key word that you guys will get in your exam is anosmia. Okay, cannot smell. This is a very crucial sign. What will they present with? I should mention, ignoring this image for now, is they'll come with eunuchoid features. Basically, their arms are going to be very huge. Okay, they might have gynecomastia. They will have, for example, hypogonadism, testicular atrophy because of the low LH and FSH, and they won't have, for example, hair. That's another important feature. And they have delayed puberty. Another important thing is I might have syndactyly, which is basically fusion of the fingers. And another important sign is this. Whenever they try to do something with one hand, for example, picking up this pen, their other hand will do the same action, which is called the bimanual synkinesis or something. Okay, exactly. So this is Kalman syndrome. You do imaging. You see, this is normal down here. This is abnormal. What's the defect? Okay. Here, you will have absence of the olfactory bulbs, which is what's causing the anosmia. And it's what's causing the Kalman syndrome itself, because Kalman is failure of the GnRH secreting neurons to migrate from here to the hypothalamus, okay, to the pituitary. So in this case, sorry, from the to the hypothalamus. In this case, they will have an absent olfactory bulb, so they won't have these neurons. Okay, hence why they have Kalman syndrome, hypogonadotropic hypogonadism. Now, these patients, how do you manage it? You just replace the hormones. Okay, you give hormone replacement therapy. How about this patient? They come to you with, I've been drinking a lot of water and I've been urinating so much more. Polyuria, polydipsia, diabetes insipidus. Good. Now, for these patients, they will typically, you'll do MRI and you'll see this. What is the defect here? How do you know that this is diabetes insipidus from the image? ADH, the bright spot. Okay. Remember the bright spot we saw earlier? This is indicative of ADH. If you have diabetes insipidus, which is central diabetes insipidus, they won't have ADH. Okay. So this is why the bright spot is gone. Now, patients with no ADH, what's happening here in these patients is ADH will usually go to the kidneys and will concentrate the urine. Okay. It's antidiuretic. You are going to try to reserve all the fluids in your body. So in this case, they're losing a lot of fluids. So their urine will be very diluted. Their serum, their blood will be very concentrated, okay? In terms of the osmolarity. They will drink a lot of water to compensate for this, okay? That's pretty much what's happening here. If you have this patient and you give them ADH, synthetic, desmopressin, will this correct their defect? Yes or no? If you give them ADH, will this fix all the issues that they have? Yes, exactly. It's opposite to nephrogenic, which is a defect in the kidneys itself. If you give ADH, it won't do anything. Okay. So they're a bit different. So this is central diabetes insipidus, pretty much. Now you have a female who just gave birth, or gave a birth, let's just say 2 weeks ago, presents to you with signs of hypopituitarism and massive headache. What do they have? It's not immediately after birth. They did not have postpartum hemorrhage. Exactly. Excellent. Lymphocytic hypophysitis. Okay. Basically, it's inflammation of the pituitary gland that causes low or hypopituitarism. That's pretty much it. In terms of what causes it, what does it, doesn't matter. Important thing for you guys to know is post or after giving birth by a certain amount of time, not immediate, and it's not associated with postpartum hemorrhage. And they come to you with a massive headache. All right, that's it. Okay, this is lymphocytic hypophysitis. Now you have let's just say a child who presents to you with a headache, who's telling you my head has been hurting, I haven't been able to concentrate at school or preschool or whatever. And you see this mass. What do they have? Craniopharyngioma. Good. Now, craniopharyngioma is a tumor of what? Where is it coming from, this tumor? Rathke's pouch. Good. If you guys remember, how does the pituitary gland develop? You have anterior, posterior. Let's ignore posterior. Anterior pituitary gland. It comes from the oral ectoderm. This oral ectoderm will give off to the anterior pituitary gland. through something called Rathke's pouch. If you have a tumor of Rathke's pouch, it will form craniopharyngioma. Okay? Now, craniopharyngioma is associated with what gene mutation and what signaling pathway? WNT. Good. WNT signaling pathway. This is very high yield. Now, what do you see on histology? Two things. Number one is the papillary, basically, or it's an adenoma. Okay. So you'll have these glands, or not glands, these basically projections. Okay. And then you have clusters of squamous cells. Okay. These are the two findings that you see on histology. So that's pretty much craniopharyngioma. Okay. Now, if someone has, before I go to the drugs you can give to replace growth hormone, let's talk about if someone has so much growth hormone, if they have acromegaly, if you were to use a certain drug to basically antagonize growth hormone, to reduce growth hormone, let's just say to decrease the growth hormone secretion, which drug do you give? Octreotide, which is a synthetic to somatostatin. And we talked about octreotide a lot in GI. You can treat esophageal varices, for example, the hormone defects, all the endocrine pancreatic tumors that we talked about, insulinoma, uh, uh, glucagonoma, and all these, VIPoma, okay? All of these can be treated with octreotide, okay? How about if you want to inhibit the growth hormone receptor? What drug can you give? And this will reduce IGF-1. Pegvisomant. Excellent. Okay, good. Now, to replace growth hormone, you have certain drugs that you can give. Firstly, it depends on the type of growth hormone deficiency that you have. Either you have primary, secondary, or tertiary growth hormone deficiency. For tertiary growth hormone deficiency, you can give tesamorelin. The most important thing about this is HIV lipodystrophy. For these patients, they have HIV. You give them tesamorelin. What will happen to these patients is they have necrosis of the fat that's in their body. This is what's lipodystrophy. Okay. Then you can give somatotropin for growth hormone deficiency in children. Okay. And the side effects that they have is due to what growth hormone is. Okay. So hyperglycemia, they might have edema, injection site reactions, and so on. And then you have mecasermin, which you can give in primary growth hormone deficiency, and basically you replace the growth hormone. That's pretty much it. The most high yield thing about this lecture in pharma is know how to inhibit growth hormone, which is through octreotide, which inhibits its secretion and synthesis, and then pegvisomant, which will inhibit the growth hormone receptor. For these drugs, the most important thing is this drug. Okay? I've always seen questions about this. Tamam? This is the most important drug. And that's pretty much it for the pituitary gland. You guys have any question before I move on to the thyroid? There's a lot of more content to discuss in these next parts of the crash course. Okay. So now the thyroid gland, which is, in my opinion, probably the funnest part of endocrine, has a lot of diseases, and it all just makes sense. Okay. So to start with the thyroid, let's talk about the anatomy and histology. So the thyroid, it's over here in front of the trachea. Okay, it has two lobes. You have the right and left lobe, and then you have the basically the isthmus that's in between them. Okay, or the infundibulum. Now the thyroid itself, it's right in front of the trachea, which is a very important thing because if you have a very big mass or a hard mass, it can compress the trachea. Now it's engulfed or encapsulated in something called the tracheal fascia, which will basically cover it and attach to the trachea, which is why when you swallow, for example, it will move. Okay. Now in terms of the histology, you have follicles. Okay. Now the follicles inside of it will be the colloid, which is this pink structure. Okay. What's lining the follicles? You have the follicular cells. Now, in between the follicular cells or the follicles, you have these small little or these big cells. These are called the parafollicular C cells. Okay. Now, these parafollicular C cells secrete what? Calcitonin. Good. Now, the follicular cells was synthesized to create thyroid hormone. You have two types, T4, T3. Okay. That's pretty much all you need to know. From this histology, the colloid is usually very big. The follicles are big. It is back to back. However, you can see the parafollicular C cells and the structures around it as well. Okay. In terms of the function, this is very important. Okay, and the axis basically of the thyroid. The hypothalamus will secrete TRH to go to the anterior pituitary gland, which will synthesize and secrete TSH. TSH will go to the thyroid gland. At the thyroid, it binds to a G protein coupled receptor, and it will cause the secretion of the thyroid hormones T3 and T4. T4 is more abundant, T3 is more potent. Okay. Now, once it goes to the cells, the T4 will convert to T3. Okay, inside the cell, and it will bind to nuclear receptors, which will then cause DNA, RNA transcription, protein synthesis, and so on and so forth. Okay. The main function of the thyroid is to increase metabolism. Okay. That's number one. So from that, it increases also the number of beta-1 receptors in the heart. It will basically cause lipolysis and so on. Okay. The main function is increase in metabolism. Okay. So that's pretty much it. The way it does it, it increases the number of sodium potassium ATPases, which will increase the oxygen consumption and so on. Okay. So that's how thyroid hormone works. Now for the pathologies or what happens with the thyroid, it just basically relates to the axis, this axis. So just normal physiology. Once you have T3 and T4 that's elevated, it will suppress TSH and TRH. Now, if you have a defect in the thyroid, is this a primary, secondary, or tertiary defect in the thyroid itself? Primary defect, okay? In the pituitary, is it primary, secondary, tertiary? Secondary. And from the hypothalamus, it's going to be tertiary. Now, if you have low T3, T4, is this hypo or hyperthyroidism? Very easy. Hypo. If it's high T3, T4, it's hyperthyroidism. Okay. So now, if you have this patient who has high T3, T4 and low TSH, what do they have? High T3, T4 and low TSH. Primary, hyper. Okay. If they have high TSH and high T3, T4, secondary, no, high T3 and T4. So high TSH and high T3, T4, this is secondary hyperthyroidism, okay? So this is basically the axis. If they have hypothyroidism, if they have low T3, T4, and high TSH, this is primary hypothyroidism. If they have low TSH and low T3, T4, this is secondary hypothyroidism. Tamam? So this is basically the terminology. Now we go into here. You have serum TSH, serum free T4, serum T3. Here in this first patient, you have normal TSH, normal T4, normal T3. What's your assessment of this patient? Euthyroid or normal? Good. This patient has high TSH, low T4, and let's just say low T3. Primary hypo. Good. Okay. How about this patient? High TSH, however, normal T4 and T3. Subclinical hypothyroidism. Excellent, good. And then low TSH, high T3 and T4. Good. Primary hyper. And then the last one, which is low TSH, and then normal T4 and T3. Subclinical hyperthyroidism. Good. Now, if you have a patient who has normal TSH, slightly low T3 and T4, however, has high reverse T3, what do they have? Illness. What do we call this? Thyroid 6 syndrome. Okay. Or euthyroid 6 syndrome. Okay. Usually happens in critically ill patients because they have high metabolism in critically ill, for example, tumor or something. And because of this, their cells are basically the 5-deiodinase in the cells is hyperfunctioning. When you have this conversion, you have an amount that turns into reverse T3. This amount will be high in these patients. Okay. So that's just a side diagnosis that you need to remember. Now, from all of these lab values, if you have any patient with a thyroid pathology, any thyroid disease, what is the first test from all of these that you ask for? TSH. And this is something very high yield for you guys to remember. TSH is the first test you do. Okay. From TSH, then you order the other things. T4, T3, and so on. You have certain lab tests that you ask for also, and we'll get to which diseases you ask for them. And then you do imaging. If you want to anatomically assess the thyroid, what imaging do you want to do first? First imaging. Very simple test. Ultrasound. Okay. Very easy. You know, imaging, you can do it in the clinic. Very easy. Okay. How about if you want to assess the anatomy and the function both at the same time? One test that will assess both of them at once. No, not CT. Nuclear uptake. Okay. This will assess the anatomy. You can see if there's nodules, if it's diffuse, if it's enlarged, and function. Okay. If it's hyperfunctioning or a hypofunction, which is through the thyroid uptake. Okay. Thyroid scintigraphy. Okay. It uses radioactive iodine, which is iodine 123, or yeah, 123, which is less, emits less beta particles, so it does not destroy the thyroid. Okay, which another thing will destroy the thyroid, which we'll get to later. So this dark tissue over here, you can see the two lobes, is the thyroid. Okay, and this is thyroid uptake. You can see the thyroid lobes if it's enlarged or not, if it's hyperfunctioning or not, or if it's hypofunctioning, and if there's any nodules. Okay, this is what you can see through scintigraphy. Now you can see other structures as well, such as the saliva, submandibular glands, and then, for example, you might see if this is the parotid or the submandibular glands, submental glands, whatever. Salivary glands is the main important thing. You might see these. Now, how does this work is, if you remember from radiology, this uses nuclear medicine. This is a very specific for the thyroid. It's iodine 123. You have another isoform of the iodine, which is called iodine 131, which is way more dangerous and destructive, and this is used as a therapeutic method. Okay. Now, to apply the thyroid uptake scan, you have two different pictures, and this is the two main pathologies that you need to be very good at. The first thing over here is this. What do you see in this first image? Hot nodule. This means that there is increased uptake of iodine. Now, with these patients with hot nodule, you suspect them to might have hyperthyroidism, okay? Because it's means it's hyper metabolic. There's function happening, so it might be secreting a lot of thyroid hormone. So this is a hot nodule. How about this patient? This is the nodule over here. Cold nodule. Is it hyper or hypofunctioning? Hypofunctioning. Is this mm, basically a benign feature or a possible mali or could it be, yeah. So it has a higher risk of cancer. Okay. So with these patients, if you see a cold nodule, especially if it's very large, you need to do a biopsy. How do you do biopsy in thyroid? For thyroid, FNA, fine needle aspiration. There are two pathologies or two organs that you need to know how to take biopsies from, or even three in repro. The first one is thyroid. You need to know that the way you take biopsy from thyroid is fine needle aspiration. In the breast, there's a specific way, and then in the cervix, there's a specific way. Okay? Exactly. Core needle for breast. And we'll get to that later on. So with patients with a cold nodule, there's higher risk for malignancy. So you need to do a biopsy to make sure. For hot nodule, it most likely it could be a more benign mass, but it's less chance that it is the malignancy. Okay. So you do other things to check for it. Now, this patient over here, what do they have? Goiter, excellent. Now, goiter just means enlargement of the thyroid gland. Okay, there is enlargement of the thyroid. We'll get to the causes of goiter because there's a lot. You have autoimmune causes, thyroiditis, toxic multinodular goiter, which could be what this patient has. And then another thing that I want you to remember is what type of food causes goiter. Do you guys know? No. C has a lot of iodine, which is you're good for saying that. But there's another type of food that's very important. Cabbage. Okay, remember cabbage. Billah, remember cabbage, okay? We got this in our exam last year as a question. Someone had goiter, what food did they eat? Cabbage. Okay. It made me really angry when I got that question. But anyways, okay. Now, moving on. You have this patient who has enlarged neck, okay, a mass in the neck that is diffusely enlarged. Okay, the thyroid is diffusely enlarged. They're telling you that they have been losing weight, that they have been more anxious, that they felt that their blood pressure is a bit elevated. They look very anxious, disturbed. They and then you check for eye examination, you see this, and you check for leg examination, you see this. What did you suspect them to have? And as someone already mentioned, Graves' disease. Okay. Now, Graves' disease is a cause of hyperthyroidism or hypothyroidism. Hyperthyroidism. Good. Now, Graves' disease is an autoimmune disease of the thyroid, causes hyperthyroidism. Now, in this case, they have antibodies. Okay. Which antibodies will you guys ask for in the lab investigations? What is your most important antibody that you ask for? The most important in Graves' disease, more specific, is the TSH receptor antibody, or they also call it the TSI, okay, antibody, okay? Because in this case, most of the antibodies, once it inhibits or once it binds to a receptor, it will inhibit it, right? In this case, Graves' disease have this antibody that binds to the TSH receptor on the thyroid and it activates it, which is why it causes hyperthyroidism. Now, these antibodies will also target the fibroblasts around the eye and in the tibia, around the tibia. In the eye, it causes this, which is what? Protruding of the eye. Exophthalmos, good. How about here? They have lower leg edema that is non-pitting. Pretibial mixed edema. Good job. So these are the two important signs that you might see in Graves' disease that you don't see usually in other causes of hyperthyroidism. Exothalamus, which is a very, very specific sign, and then you might see the pretibial mixed edema as well. Okay? You do thyroid uptake scan and you see this. What is your diagnosis? Graves' disease, excellent. Now, in Graves' disease, there is diffuse uptake of the entire thyroid. Okay, the entire thyroid will be enlarged and there's diffuse uptake. Okay, this feature is very important and this image will come in your exam. One of these two. If in OSPE, it will come as MCQ, patient with characteristic Graves' disease, as I mentioned. And then they'll ask you which one is associated with Graves' disease or which image, and you choose this one. Diffuse enlargement and diffuse uptake is the key terms. Okay, please remember that. The antibody that usually they ask for is TSH receptor antibody, TSH receptor. Anti-TPO, anti-thyroid peroxidase, is associated with another autoimmune thyroid disease, and we'll get to that later. Okay. Now you do firstly gross, it's diffusely enlarged, both sides. You do histology, you see scalloped colloid, which is all of these white spots that's scalloping into the colloid. And you see these papillary projections with no fibrovascular stalk. What is this disease? Graves' disease. Okay. This image is very high yield histology. Okay, remember this description. Scalloped colloid. They might give it to you in the scenario itself. Scalloped colloid, papillary projections with no fibrovascular stalk. Okay, this is a key description of Graves' histology. Now, you do have certain genes associated with Graves' disease, unfortunately, more genes to memorize. But what are these genes? You have three genes. CTLA4, PTPN22, and one more. What is that last one? That's seen in both Graves and another autoimmune thyroid disease. I'm not sure about that one, but the one I was looking for is IL-2 receptor alpha. Okay, that one. Okay, that's it. Okay, remember these three genes. CTLA4, PTPN22, and then IL-2 receptor alpha. Okay, these three genes are associated in Graves' disease. And I'm pretty sure you're right about HLA. I think it's D8, or I'm not sure if it's DR3. It could be, I don't know. But you guys check that. How about this patient? This patient has been complaining to you that they are feeling very lethargic, very slow. They have been gaining a bit of weight. Their hair is very dense, I guess. They've been very slow. What do you suspect them to have? Hypothyroidism and depression. Okay. Hypothyroidism. You have many causes of hypothyroidism. The main important cause is thyroiditis. Okay. Inflammation of the thyroid. Now, in thyroiditis, just for your guys' concept, the very beginning of thyroiditis, do you have hyper or hypothyroidism? The very beginning. Hyperthyroidism. What's happening in thyroiditis is you have inflammation, something that's causing inflammation of the thyroid. When you first have inflammation of the thyroid, it dumps all of the thyroid hormone that it has into the circulation. So this causes hyperthyroidism. 2 weeks later, somewhere around that, they will deplete their thyroid hormones. So they'll have hypothyroidism. And later on, they might go back into euthyroid, okay? Which is usually what happens. Now you have the infectious causes or inflammatory causes, then you have the one autoimmune cause that I want you guys to know. Okay. Uh, Now in this patient over here, you do thyroid uptake and you see absent uptake. This is what? Absent uptake or low, very low uptake? What do they have? Hypothyroidism or thyroiditis. Why is it hypofunctioning or why is it low uptake? It's because, again, the thyroid itself is not synthesizing and secreting the hormone to cause the initial hyperthyroidism. It's just dumping everything. So it's not really functioning. There's just inflammation happening in it. That's why it's low uptake. Okay. And this is what's seen in thyroiditis or hypothyroidism. Okay. Now, for the first patient that you have here, you have signs of symptoms of hypothyroidism. They are a 30-year-old female with other autoimmune diseases. What do they have? And they have signs and symptoms of hypothyroidism, Hashimoto thyroiditis. Again, autoimmune cause of hypothyroidism. Now, with these patients, again, they have inflammation of the thyroid. So you'll have here germinal centers forming and follicles forming with a lot of inflammatory cells surrounding it. And then you have this cell that is very characteristic in Hashimoto thyroiditis, which is what? Erythroid cell. This cell is very high yield, guys. Very, 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 very high yield. تمام. Please know this for your exam. Okay? تمام. Now, for this patient over here, they have signs and symptoms of hypothyroidism. Now, before that, actually, for Hashimoto thyroiditis, the same genes that I've mentioned, CTLA4, PTPN22, and IL-2 receptor alpha. Same genes are associated in Hashimoto thyroiditis. Okay? It causes hypothyroidism, as we already mentioned. Now, for these patients, this one, they have signs and symptoms of hypothyroidism plus a painful thyroid. What do they have? Painful. Key term, painful. Decorvain thyroiditis. Another name is subacute granulomatous thyroiditis. From the name, subacute happens 2 to 4 weeks after an infection. Okay. Granulomatous is it forms granuloma on histology. Okay. So you have this granuloma formation with giant cells. Okay. As every granuloma, everything that I've explained this entire year to you guys. Granuloma. Okay. Giant cells. The key term in description of your question stem is painful thyroid. Please remember painful thyroid. Tamam? Okay. How about this patient? 2 weeks after an infection, comes to you with firstly signs of hyperthyroidism, then it slowly became hypothyroidism. 2 weeks after infection, and they have a painless thyroid. They just had infection with a virus. Lymphocytic, good. Lymphocytic thyroiditis or subacute lymphocytic thyroiditis. Difference between this, it's very similar to Hashimoto, very similar. The difference between this and Hashimoto thyroiditis is this one will not have erythroid cells. Okay? You have lymphocytic infiltration and so on, but no erythroid cells. Okay? These things over here, by the way, are the follicles. They're very small in this case because of the inflammation that's happening in the thyroid. Okay? And this is very self-limiting, it'll go away. Now, this patient, again, has signs of hypothyroidism after 4 weeks of something. And the description that I will give you is it is a very rock hard thyroid. Rydell's thyroiditis. Good. What is seen on histology? What is all of this? All of this. Fibrosis. Good. So Rydell's thyroiditis, the main important thing that I want you guys to remember is this description. They might have signs and symptoms of either hyper or hypothyroidism, depending on the timing. Usually we'll describe it to you as a hypothyroid patient with a very rock hard, solid thyroid. It's painless, however, it's rock hard thyroid. This is Rydell's thyroiditis. Okay. How about if they have painful thyroid? What is the differential again? Because this is a very important differential. Granulomatous or decurvain thyroiditis. Good. Tamam. Now you have this patient who has signs of hyperthyroidism, and then you do scintigraphy. What do they have? Just diagnosis from the image itself, not the pathology behind it. You're correct. It is a hot nodule, but there's something else I can tell about it. Can you see the surrounding thyroid around it? The rest of the thyroid? Yes or no? Yeah, exactly. No. So because of this, I can say this is a solitary toxic nodule, okay? Or autonomous nodule. Why? It's secreting, it's so hyper functioning that all the iodine is going there, okay? That's why we can say it's a toxic nodule, okay? It's not just a hot nodule, it's a toxic nodule, very hyper functioning, okay? That's why I can't see the rest of the thyroid around it. If you can see the rest of the thyroid, then I'd say, okay, this is most likely just a hot nodule, okay? This is just something to know the image of. There's nothing else behind it. Okay. Now, this patient comes to you with signs of, let's just say, initially hyper, then later on become hypothyroidism, and they have a very enlarged thyroid that is multinodular. You see many different nodules. You do an ultrasound, many different nodules. What do they have? Exactly. TMJ or toxic multinodular goiter. Okay, again, just know the image for this. You can see multiple hot nodules or areas where it's hyperfunctioning and areas that are hypofunctioning or cold nodules. The key point here is that it's multinodular. Tamam. How about this patient? They've been telling you that they are asymptomatic and have a slowly enlarging mass in the neck. You do scintigraphy and you see this. What's seen on the image first? Describe the image. Cold nodule. It's hypofunctioning. Okay. So this nodule is hypofunctioning. Okay. Hence, it's a cold nodule. It raises suspicion for malignancy, as we mentioned. Okay. So for this patient, it is a must that you take biopsy through FNA. Okay. It is a must. Now, there is a criteria or methods you do to diagnose thyroid diseases, and we'll mention that at the very end. Okay. Now, the first patient that you saw with this cold nodule, you did biopsy and you did a thyroidectomy, removed it to assess for this mass. Can you tell me what is the diagnosis of this mass over here and histology? Adenoma. Why adenoma and why not carcinoma? What tells you it's an adenoma and what tells you it's a carcinoma? Okay, follicular can happen. Exactly. The most important is capsule. If it goes through the capsule, which is more evident here. Is it invading the capsule? Yes or no? This mass. This is a tumor. Is it invading the capsule? No, it's not. Over here, you can see normal follicles. This is what's telling me that this is a thyroid adenoma. It's a very big mass, singular mass, and it's of the follicles. Okay, so you could say this is a follicular adenoma if you really want to. You have multiple follicles, different sizes. You might see atypia, such as over here. However, if there is atypia, I'm still not going to call it a carcinoma. Okay? I will only call it a follicular carcinoma or a thyroid carcinoma is if it invades the capsule. In this case, there is no capsular invasion. Okay, past the capsule, it's normal. So this is why I can say this is an adenoma. And this is also part of the reason why they did a thyroidectomy. Usually with these patients, you still perform a thyroidectomy because you need to see capsular invasion. Okay, remove the thyroid and send it to biopsy. Okay. Now, one subtype of adenoma is this. What can you guys see? What type of adenoma is this? Peripheral cell adenoma. Perfect. Similar to the cells that we saw in Hashimoto thyroiditis, it's just an adenoma of those cells. Okay. The only thing you need to know is just this image. Okay. This one over here, that's basically a peripheral cell adenoma. You might say that this image has some atypia and so on, such as over here, but it's not too important. The most important thing is just remember that peripheral cells that you might see and that you see in Hashimoto's might have an adenoma, which is peripheral cell adenoma. Okay. How about this patient? Enlarging thyroid mass might be associated with weight loss, constitutional symptoms, and so on. And the mass is not functioning. Cold nodule, larger than 2 centimeters. Cancer. What cancer are you suspecting here? Carcinoma. Good. So there's 4 types, right? Papillary, follicular, medullary, and anaplastic carcinomas. This one is usually papillary thyroid carcinoma, has these cystic lesions and so on. This might be papillary thyroid carcinoma. Do you need to remember it grossly? No, you need to know it histologically, which is this. This is a very important histology. Firstly, what is the carcinoma in this question or in this image? Papillary. Good. Now, firstly, let's talk about this image. It's papillary lesions, hence papillary, papilla, with fibrovascular core. In Graves' disease, you had the papillary lesions, however, they did not have fibrovascular core. This is the difference between them. This one has a fibrovascular core, which is this, which has all the blood vessels that's going into the tips of the papilla, okay? Now, this image is the most high yield. What do I call this feature? Orphan Annie eyes. Good. Okay. This is the most high yield thing about the carcinomas. Okay. You need to identify papillary thyroid carcinoma very, very well through this image. You might see intranuclear inclusions and intranuclear bodies and so on. Okay. Orphan Annie eyes are the most important feature. Another very important feature is this. What is that? Somoma bodies. Excellent. Good. So these are the somoma bodies. The 3 things that I mentioned. You have papillary lesions with the fibrovascular core. You have the orphan Annie eyes with intranuclear inclusions and intranuclear bodies and grooves and so on. And then you have the somoma bodies. These are the signs that you see on histology. Okay. Now, what genes are affected in papillary thyroid carcinoma? Good. Perfect. Okay. RET, PTC, and BRAF. RET PTC is a very important gene that I want you guys to remember for a while, because later on we'll talk about the syndrome associated with RET PTC. Okay. Anyways, where does this tumor spread to? Does it spread to the blood or through lymphatics? Lymphatics. Okay. Okay, that's pretty much it. Carcinomas typically spread through lymphatics. That's the key term, but there's exceptions here and there. Okay. So that's for carcinomas. For sarcomas, they typically travel through blood. Okay, but that's just outside information. The reason why I mention this is for this type of tumor. Now, this tumor, what is the diagnosis? Follicular thyroid carcinoma. Good. Now, why is it a carcinoma and not an adenoma? Again, this concept needs to be very clear to you guys. Capsule invasion. You can see it's going into the capsule. Okay? So this is where the capsule is supposed to be. However, it's going into the capsule and invading it. Tamam? So this is why this is follicular. Thyroid carcinoma. Why is it follicular? You can look at the follicles. Okay? Basically atypia of the follicular cells with a limited amount of colloid, small follicles, and so on. And atypia, most important sign is invasion of the capsule. Tamam? Now, what genes are affected in follicular thyroid carcinoma? This one has a good amount. RAS, excellent. This is probably one of the more high yield ones to remember for follicular. What are other ones? PPAR gamma, PAX8, good. Good. Okay. PPAR gamma, PAX8, P10, PI3 kinase, and RAS. Okay. Where does this tumor spread to? Blood, exactly. This is not a typical feature. However, it spreads through blood, okay? And bone. Now you have this patient again with an enlarging thyroid mass, however, has hypocalcemia. And yeah, has hypocalcemia. Medullary thyroid carcinoma, good, excellent. Now, what is abundant in medullary thyroid carcinoma? What is all of this and this pink thing? Amyloid, good. So how do you stain it with what stain? Congo red stain, which shows you what in this image, all of this bifringence. This is the apple green bifringence. Okay, so this is medullary thyroid carcinoma. Very importantly, is what gene is mutated in medullary thyroid carcinoma? RET. Very important. Okay, is RET. Okay, why? We'll talk about this later. What does this tumor secrete? Well, you mentioned that this patient had hypocalcemia. So what did they have that's abundance? Calcitonin. This tumor is from the parafollicular C cells. Okay, so it secretes a lot of calcitonin. That's a typical hormone. However, this patient might also have watery diarrhea. So you might see, okay, VIP. Might have serotonin syndrome. So you might say, okay, maybe serotonin as well. Okay, so there's a lot of different things or hormones that this tumor can secrete. The most common and classical is calcitonin. Now, how about this patient? Let's just say they had a follicular carcinoma. They avoided treatment. They were very poorly compliant. And it comes to you with a very big thyroid. Trachea is compressed. They might have dyspnea, difficulty breathing. You do biopsy and you see this. This is anaplastic, okay? Thyroid carcinoma. The word anaplastic, if you remember anaplastic, if you remember from Dr. Alban, it just means very, very ugly. And this is exactly what this tumor is, okay? The cells are very, very large. It looks very ugly and bad, okay? So this is anaplastic. Now, with a lot of these tumors, you can detect it by using thyroglobulin, which is a tumor marker for thyroid. However, in this patient, if you check for thyroglobulin, would it be positive or negative? Negative. What will be positive in these patients? Epithelial markers. Excellent. Good. So you do immunohistochemical staining and it'll be positive for epithelial markers. However, it will be negative for TTF and thyroglobulin. Okay. TTF and thyroglobulin is typically positive with the majority of the other carcinomas. However, the more common one that you guys need to remember is follicular carcinoma. Tamam? Now, is this prognosis of this tumor good or bad? Bad. However, for the other thyroid carcinomas, is it good or bad for the other ones that we talked about before? Good. Typically very good. Thyroid is a very, from all the other cancers, it has a very good prognosis and patients are treated very well. Okay. Now, this patient over here is a child who has lethargy, poor development, neurological development, coarse facial features. Their tongue is protruding outwards and it's very large tongue. And they have, on physical examination, umbilical hernia. What is your diagnosis? Someone mentioned this in the chat a very long time ago. Cretinism, good. So this patient has cretinism, which is congenital hypothyroidism, maybe due to iodine deficiency, maybe they were taking their mothers were taking anti-thyroid medications while this patient was or while they were still in utero. You never know. So this is cretinism, okay? Which due to neurological or poor neurological development and neurological delay, as I mentioned, coarse facial features, signs of hypothyroidism, other signs such as lethargy and so on. And then they also have a large tongue, protruding tongue with an umbilical hernia. This is typically how it's described. Okay. This is cretinism. Now, over here, the same patient, okay, has hypothyroidism. You do ultrasound, you can't locate the thyroid. Okay. However, then you do the scan and you see this. What do I say about this? Ectopic thyroid. Okay. Where is the most common location for ectopic thyroid? Sublingual. Good. For the reason why it's sublingual or lingual thyroid, okay, the reason why is that from the development. The thyroid develops from the tongue. There is a groove between the anterior two-thirds and posterior tongue. Okay. It's called, or the remnant of it is called foramen cecum. Okay, very advanced stuff right now. So anyways, it forms the thyroglossal duct. It descends all the way down into the location of the thyroid, okay, which is on the anterior neck, okay? So in this case, if you have any ectopic thyroid, the most common location will be at the beginning of the whole route, okay, at the sublingual or the lingual thyroid, okay? So which is what you can see here. This is an ectopic thyroid. Now, to diagnose patients with thyroid, let's talk about diagnosis and management of thyroid diseases, okay, before we move on. First test you do, screening test for all patients, is you do TSH. After TSH, you want to see if they have hypo or hyperthyroidism, okay? Or if it's high TSH and they have symptoms of hypothyroidism, then you can say, okay, this is primary hypothyroidism. Anyways, the first thing you do is TSH. Then you do T3, T4 to correlate with TSH. If you have high T3, T4 and low TSH, this is primary hyperthyroidism. Opposite, primary hypothyroidism. So then you go on from there. You do an ultrasound as well. Okay. Now from the ultrasound, you can see if it's diffusely enlarged, if there's nodules, multinodular, and so on. Based on this, you also can, if they have, for example, if they're 30-year-old with low TSH, high T3, T4, with signs of hyperthyroidism, ultrasound shows you they have diffuse thyroid enlargement, then you can order thyroid other lab investigations, such as the TSH antibodies that we mentioned. However, if they have, for example, another patient who's a 30, 40-year-old, or even elder, more older than that, like around 50s, coming to you with signs of hypothyroidism, you do firstly thyroid screening, TSH levels. First lab test you do, TSH, and it'll be high. T3, T4 will be low. And then you do ultrasound, you don't really see anything that's conclusive. You don't see masses. You might see it as a bit enlarged, but that's it. Okay. Now, in this patient, you might order a certain lab investigation, which is anti-thyroid peroxidase antibodies for Hashimoto. Okay. Now, after the initial testings, TSH, T3, T4, antibodies if you want, depending on if it's Graves or Hashimoto, and also ultrasound, then you need to go over other tests. The next test, best test to do is the thyroid uptake. Okay. Now, if the thyroid uptake will show you cold nodule, if the nodule is above 2 centimeters, you need to take biopsy. You have to take biopsy, okay, which is through fine needle aspiration. And then if it doesn't, if it's hot nodule, diffusely enlarged, you treat the underlying cause, such as Graves' disease or whatever. In terms of the management, for hyperthyroidism, you treat it with medications. If it didn't work, you can treat it either with surgical or with radioactive iodine. Okay, this is mostly for Graves' disease. This is the trio therapy for Graves' disease. If they have hypothyroidism, it's very simple. Okay, your life is easy. You just treat it with thyroid replacement therapy. If they have cancer or an adenoma or a tumor, you treat it surgical. Okay, so now let's start with hypothyroidism. How do you manage it? With thyroid hormone. Now, you have two drugs to treat thyroid hormone, okay, or thyroid replacement. You have levothyroxine and liothyronine, okay? Levothyroxine, is it a synthetic T4 or T3? T4, good. Which one? And then liothyronine, is it T4 or T3? T3, good. From these two, which ones do you prefer to give the patient for a long-term therapy? Levo or Leo? Thyrene, levothyroxine. Why? Because it has a much, longer half-life, so the patient compliance would be much better. Liothyronine is a very short half-life. What are the complications of levo or levothyroxine? Liothyronine is hyperthyroidism. Makes sense. Okay. How do you monitor patients with levo or liothyronine? With TSH levels? Okay, you monitor them through TSH levels. Tamam. That's pretty much thyroid replacement. How about thyroid medications? For thyroid medications, you have multiple steps that you can basically target the thyroid hormone. The first part is at the sodium iodine cosymporter, or the symporter. Then you have the thyroid peroxidase. And then you have also later on at the peripheral deiodinase enzyme, okay, which is the peripheral conversion of T4, T3. These are the main important ones, with some on the proteolysis and so on. The first one is the sodium iodine symporter. You inhibit it by perchlorate, or there's another drug, which is what? Perchlorate or thiocyanate. Good, excellent. Which inhibits the symporter. Less iodine will be able to come in, and then less iodine that's in will reduce the amount of T3 and T4 that you can synthesize. Okay, so that's this symporter. The other one, which is very important, is thyroid peroxidase enzyme. This can be inhibited by iodide or by thionamides. Thionamides, let's talk about this one first. Thionamides, there's two types that I want you guys to know. Propylthiouracil and methimazole. Okay? These are the two. They inhibit the thyroid peroxidase. Propylthiouracil has an additional activity or action, which is against the peripheral deiodinase enzyme. Now, for these thionamides, what is the most important side effect? A, granulocytosis or granulocytopenia. Excellent, good. A, granulocytosis. Now, with propylthiouracil also, it has hepatotoxicity also as a side effect. Another important concept. Methimazole is teratogenic in the first trimester. So if you have a patient who's pregnant in the first trimester, do you prefer to give propylthiouracil or methimazole? PTU, propylthiouracil. After the first trimester, you switch to methimazole for the rest of the second and third trimesters. Okay? This is for patients who have hyperthyroidism who are treated with these medications. However, outside of pregnancy, methimazole is the drug to go to. It has less hepatotoxicity. That's why you go for methimazole. Okay? The next drug that we'll talk about is iodide or potassium iodide, which inhibits the proteolysis for the release of the T3, T4, and inhibits the thyroid peroxidase. The implication of this potassium iodide is that it can be used in thyroid toxicosis, and I'll talk about this in just a second. Now, the last drug that I want to talk about in terms of antithyroid medications is propranolol, which is beta-1 receptor blocker. Okay. Now, propranolol, it's a non-selective beta blocker. It inhibits beta receptors and inhibits the peripheral conversion of T4 to T3. So in the case that the patient has thyroid toxicosis or thyroid storm, this drug is very important because in thyroid toxicosis or thyroid storm, they have palpitation and tachycardia. So you want to hit two birds with one stone, decrease the heart rate and decrease the thyroid or peripheral conversion of the thyroid hormone by giving propranolol. Which brings me to this. In the case that the patient has thyroid toxicosis, what drugs do you give? There's the P's that you need to remember. Number one, propranolol. Give them propranolol. Number two, give them propylthiouracil, and then you can give potassium iodide as well. Okay? These are the drugs that you give for a patient with thyroid toxicosis to reduce the amount of thyroid hormone, to reduce the tachycardia, to reduce basically the release of the thyroid hormones. Okay, synthesis and release and peripheral conversion. These are the anti-thyroid medications. Okay, this is basically the pharmacology of the thyroid done. There is another thing. In case of patients with Graves' disease or hyperthyroidism, you can treat it with radioiodine therapy. Okay, radioiodine therapy, which is basically you give them iodide 131, okay, which emits a lot of beta particles, which is very toxic. It's very selective to the thyroid tissue through this transporter, okay? It goes into the thyroid and it destroys the thyroid from within, okay? The good advantages of this is it avoids surgery, okay? And avoids all the complications of surgery. The bad parts of it is it can lead to permanent hypothyroidism, which is what's suspected, yani. That's why you're doing this procedure, okay? So you replace it with levothyroxine after the procedure, okay, after giving the radioactive iodine, okay? This is basically thyroid pharma, pretty much in a nutshell. Remember the side effects of the thionamides, okay? Propylthiouracil and methimazole causes a granulocytosis. Remember that PTU has more of a hepatotoxicity, hence methimazole is usually given. In pregnancy, methimazole is teratogenic in the first trimester. So you give PTU in the first trimester, then switch it back to methimazole in the second and third trimesters. Remember this for the thyroid medications and thyroid pharmacology. Tamam? Now, the result for this patient with Graves who needs surgery or for the adenomas and cancers is something called a thyroidectomy. You remove the thyroid. There's two types. There's complete versus subtotal, or hemithyroidectomy, which is removing half the thyroid. The surgical stuff about them, it's not too important. However, you do a midline incision through or transverse incision, remove the muscles that's in front of it, which is thyroid, sternocleidomastoid muscles, remove it, and then remove the thyroid. The most important thing for you guys to remember about this is two things. Number one is when you're ligating the inferior thyroid artery, okay, and the superior thyroid artery, there is an important nerve that's around this area, especially around the superior thyroid artery, okay? What is that nerve, if you guys remember, around the thyroid? Laryngeal, recurrent laryngeal nerve. This is a very important thing for you guys in thyroidectomies, okay? Because you might injure the recurrent laryngeal, which leads to hoarseness of voice, okay? Bilateral would lead to voice cord paralysis, okay? So that's recurrent laryngeal nerve. You have another nerve, which is a superior laryngeal nerve, which leads to issues in the like high-pitched vocal sounds if it's injured, okay? Another thing is there's an organ right behind. There's four organs right behind the thyroid. What are these organs or glands? Four of them. Parathyroid. So what do you suspect if you remove the thyroid with the parathyroid? What will you have? If you remove the thyroid with the parathyroids, you have hypoparathyroidism. This is the most common cause of hypoparathyroidism, and we'll talk about this in a bit. And it's one of the most important complications. Another thing is you might have bleeding and then the neck, there's a lot of space. So if you have bleeding in the neck, it's very, 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 very dangerous because it can cause tracheal compression and the patient won't be able to breathe anymore. Okay. That's pretty much thyroidectomy and that whole clinical lecture basically for you guys. Okay. And all of pharma. So this patient came to you way after they had a tumor, they removed it. What do you see here? Do you see a thyroid? Yes or no? And you see a transverse neck scar. You don't see it. So this is post-thyroidectomy, okay? So this indicates to you that this patient had a thyroidectomy and it worked very well. The reason why I say it worked very well is there's no more residual mass. There's nothing, okay? So it was successful, okay? Do you guys have any questions for the thyroid before we move on to the parathyroids? Anything you guys want me to repeat? Okay. Do you guys want a break? Because we have parathyroid very short, and then diabetes, and then adrenal gland. Or do you guys want me to continue? Okay. I guess I'll continue, and then we'll see after parathyroid. So, parathyroid, very easy. Very, 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 very simple. But basically, we have four glands, okay? Behind the thyroid, right posterior to the thyroid, okay? Two superior, two inferior parathyroids. Now you can see that there's a lot of white adipose tissue, which is all the fat in the parathyroid, and then you do histology, and you see all these cells. These cells are called chief cells. These cells are called oxyphil cells, okay, which are these large pink cells. Are these cells important? Not too much. No chief cells. Chief cells are what secrete PTH. Now, the most important stimulus for the secretion of PTH is calcium, okay? The parathyroid has something called the calcium sensing receptor. If there's high calcium, the parathyroids are going to see this and say, okay, I'm not going to give you any more parathyroid to increase the calcium anymore. So I'm going to chill down and not give you any more PTH. So it reduces the synthesis of PTH. In the case of low calcium, this calcium sensing receptor will activate. We'll be like, okay, there's no calcium. So it's going to start to secrete PTH. Now, what will this PTH do? PTH has direct activity in two organs, the bone and the kidney. Okay. In the bone, it's gonna cause increased bone resorption. So it's gonna increase osteoclast activity. It's gonna increase calcium and phosphate in the blood, both of them. Okay. Then in the kidneys, it will do three things in the kidneys. Number one, increase calcium reabsorption. Number two, increase phosphate secretion. And number three is vitamin D activation through the activation of the 1-alpha hydroxylase enzyme. These are the direct action of PTH. How about indirect? It's through vitamin D. Once it gets activated to 125 dihydroxycholecalciferol, which is the activated vitamin D, this activated vitamin D will go to two organs, bone for the same effect as PTH, and the intestines. In the intestines, it increases the absorption of calcium and phosphate. Okay? The net result of PTH is just to increase calcium. In the kidneys, you'll have increased phosphate secretion. In the intestines, you have increased phosphate absorption. So it just maintains homeostasis. Once you have increased calcium, okay, this will go back to the parathyroid and be like, okay, enough PTH, okay, and you'll have inhibition. So this is just in the homeostasis. Now, in the case of if you have hyperparathyroidism, okay, now let's just say this is primary hyperparathyroidism in terms of it's something in the parathyroid glands, okay? PTH will be very high. Now, PTH will go to the bone, which will cause increased calcium and increased phosphate. It will go to the kidney, which will cause increased calcium and decreased phosphate, and very decreased phosphate, okay? In the kidney, it will cause vitamin D activation. And then in the intestines, you have the calcium absorption with the phosphate. Now, for patients with primary hyperparathyroidism, which is something in the parathyroid that's causing PTH secretion, what will the calcium levels be? Hyper or hypocalcemia? It will be hypercalcemia, okay? How about phosphate? Because in the urine, it's secreting a lot of phosphate. So what will it be? Hypo or hyperphosphatemia? Hypo, okay? Low phosphate. In the urine, will it be high calcium or low calcium? Very important in the urine. Good. Okay. It's reabsorbing a lot of it. Now, how about, let's just see if you know the cyclic AMP, will it be high or low in the urine? If you know. It'll be high. The reason is because it's high, it's functioning a lot. The PTH is going to the kidneys and it's causing it to function a lot. So high cyclic AMP. Okay. So that's basically that. Okay. Now, the other disease is secondary hyperparathyroidism, which is usually due to what disease? Chronic kidney disease, CKD. So in this case, the parathyroid will compensate for the chronic kidney disease and it will cause hyperparathyroidism. The calcium levels in chronic kidney disease will be high or low? And in secondary hyperparathyroidism, low. So there will be low calcium, hypocalcemia. This hypocalcemia will cause secondary hyperparathyroidism. Now, phosphate, will it be high or low? High. In secondary hyperparathyroidism, it will be high. Why? Is because there's chronic kidney disease. Okay, the parathyroid will go to the kidney and try to do its action, however, it can't because there's kidney disease. Okay, so it's not going to be able to do that. Another important thing about this phosphate, which will be high in secondary hyperparathyroidism, is this will worsen the calcemia, hypocalcemia. Why? Is the phosphate will bind calcium, okay, in the blood. Now, when it binds to calcium, there's less free ionized calcium. So this will worsen the hypocalcemia much, much more, okay? However, PTH will be high in this case. Vitamin D, will it be high or low in chronic kidney disease? Low. Why is activated vitamin D? It will be low because it's not going to be able to be activated, okay? Simply because of that. That's pretty much the diseases. Now, hypoparathyroidism is most commonly due to what? The next disease. Hypoparathyroidism. Thyroidectomy, okay? It's most commonly due to thyroidectomy. Remove the remove the parathyroids with the thyroids. And it causes hypoparathyroidism, which will be low calcium, most importantly, high phosphate. Vitamin D is not affected. Vitamin D will increase, okay? Um, or it won't be low. It won't be the active form won't be very low because the kidney's fine, okay? That's pretty much for hypoparathyroidism, okay? But the most important test here is PTH. In hypoparathyroidism, PTH will be low, okay? That's why it's hypoparathyroidism. Now, for the main tests that you do for parathyroid is you have PTH and calcium, and then you have others such as phosphate, okay? And then you need to do urinary calcium and yeah, and you go from there. So the normal, what will happen is, as I mentioned, if you have increased calcium, PTH should go down. If PTH goes up, calcium will go up, but then PTH will go down. Okay, it's just for homeostasis. In the case of hypoparathyroidism, most likely due to surgical resection, most common cause of hypoparathyroidism, the parathyroid will go down. Because the parathyroid goes down, calcium will go down with it because you won't have the function of the parathyroid as we mentioned. For primary hyperparathyroidism, PTH will be secreted and calcium then will go up because of this. However, the calcium won't be able to feedback inhibit PTH anymore because of either hyperplasia of the parathyroids or an adenoma, most commonly, okay? Now, secondary hyperparathyroidism is when you have chronic kidney disease or vitamin D deficiency. Now, in secondary hyperparathyroidism, it is the low calcium because of the kidney disease or vitamin D that's causing feedback loop or positive feedback and causing the hyperparathyroidism to compensate for the low calcium. Okay? Now, tertiary hyperparathyroidism is if you have uncontrolled secondary hyperparathyroidism and it's autonomously being secreted, okay? The PTH, and this causes tertiary hyperparathyroidism, okay? Now, what are the signs and symptoms of hyperparathyroidism and hypoparathyroidism? Now, hyperparathyroidism will present with this. You will have hypercalcemia, and you will have hypercalciuria, not hypo. Okay, so the calcium in the urine will be high. The reason is not low. This is a correction for before. The reason is because the calcium load is going to be so high now that in the urine, it's going to go to the urine. Okay, and it will flow in the urine. So this is a risk factor for kidney stones. They will have polyuria because of the osmotic load coming from the calcium, hypophosphatemia, as we mentioned, high PTH, which is what's causing, all of this. High alkaline phosphatase, why? Is because of increased bone resorption, increased urinary cyclic AMP, and then they might have bone pain because of the increased bone resorption, weakness, constipation. Remember from GI that we mentioned is that high calcium causes constipation. Flank pain because of kidney stones, and then you have neuropsychiatric disturbances or psychiatric overtones from the high calcium. Okay. This later on, because of the increased bone resorption, causes cysts to form in the bone. This is called osteitis fibrosis cystica, and we talked about this in MSI. Okay, and it's because of the high amount of PTH is activating so much osteoclasts, so many osteoclasts, so it's going to form cystic spaces that's going to be basically filled with blood, and we'll see an image of this later. Okay. Secondary hyperparathyroidism, as we mentioned already, it's due to chronic kidney disease, and we mentioned all of that. And tertiary is from autonomous, from end-stage renal disease. Okay. Renal osteodysease is bone lesions due to the secondary and hyperparathyroidism. Same mechanism, osteoitis fibrosis cystica. However, this one is mostly due to primary. Renal osteodystrophy is most likely due to renal disease. So you have secondary and tertiary hyperparathyroidism. Okay. Now, let's talk about primary hyperthyroidism first. Someone is coming to you with bone pain, had kidney stones before, tells you I have constipation, and has a slightly increased mass, singular mass, in the right lower neck. You do a uptake, okay, and you see this. What is your diagnosis? Parathyroid adenoma. Excellent. Firstly, you will do labs. You'll see high PTH, high calcium, low phosphate, high urinary calcium. And this will tell you that this patient has uh, primary hyperparathyroidism. You do this uptake, which is the MIBG, the MIB scan, MIBI scan, which is very specific for the parathyroid glands. And it will show you uptake in one of the glands, not all four, one of them. So this is parathyroid adenoma, which is a tumor that's secreting high amounts of parathyroid. What is this? What does this patient have? Same presentation, same case. They have parathyroid adenoma, which is basically a tumor, benign tumor of the what's it called? The chief cells. Okay. And the chief cells will secrete a lot of parathyroid. That's pretty much it. Okay. That is parathyroid adenoma. An important thing to remember about parathyroid adenoma is firstly, it's associated with a syndrome, and we'll talk about this later. Second of all, is the size of the parathyroid. Dr. Abrar loves this concept, is that the size can reach up to 5 grams. Okay. Um, it's one of the glands only will be very, very heavy. Okay. And it's one gland only. Okay. Not all four. If it's all four, this is called parathyroid hyperplasia. Okay. And again, it's probably due to secondary due to what's it called? Chronic kidney disease. Now, very rare is this. What does this patient have? Again, has primary hyperparathyroidism. Parathyroid carcinoma, okay? Nothing too much to explain here. It's much more anaplastic and much more anaplastic, and it's not uniform like the adenoma where you can see a lot of T cells and oxyphil cells as well. Okay? This is parathyroid carcinoma. Now, a complication of primary hyperparathyroidism is this. What does this patient have? This is a picture of their bone. Good. Osteitis fibrosis cystica. Okay. You can see all of these are osteoclasts. They're very active. It's going to form cystic spaces that's going to be filled with hemosiderin, which is why it's also called brown tumor of the bone. Okay. This is osteitis fibrosis cystica. Now, this patient over here has a parathyroid adenoma, has hyperparathyroidism. However, when you do, let's just say you did ultrasound, you can find the adenoma, everything looked normal. You do a MEB scan, okay, for the parathyroid, and you locate it in the thoracic cavity. What do we call this parathyroid? It's very low. similar to the thyroid that we located in the tongue. Not small cell. It's just not in its ectopic. Okay? It's not in its correct area. Okay? Embryologically, if you guys remember, the parathyroid, it's coming from the pharyngeal arches. It will descend down. Okay? When it's descending too much, it will go all the way down to the thoracic cavity. That's pretty much it. Okay? So this is the ectopic parathyroidism. Okay? It just descends too much. Now, this patient had, let's just say, Graves' disease. We did surgery on her and we removed the thyroid. And later on, presents with these two clinical features. Firstly, what happened to this patient and what do they have? Hypoparathyroidism, excellent. Which causes hypo or hypercalcemia? Hypocalcemia. So what is this sign called with the blood pressure cuff? Trizo, good. How about this patient? You tap on the face, Schaffsek, good. You tap on the face and it causes spasms. This is Schaffsek's sign, okay? These are the two signs of hypocalcemia coming from hypoparathyroidism. Okay. Do you guys have any questions for the parathyroids, or do we continue to the pancreas and diabetes? Okay. So, so pancreas and diabetes. So firstly, pancreas histology. We covered the pancreas extensively in GIT. Okay, in terms of its exocrine functions and then pancreatitis, acute chronic cancers. Okay, we covered that extensively. One thing we didn't mention is the endocrine pancreas. So the endocrine pancreas is a small portion of the pancreas, and it's responsible for all the hormone secretions. What is this thing over here? This is the islets of Langerhans, okay? This is what has all the alpha, beta, delta cells and some other cells that secrete insulin, glucagon, somatostatin, and so on. Further on, you do staining specifically to see the different types of cells that the islets have, and you have alpha, beta, and then delta cells. The beta cells are very abundant, and it's responsible for secreting insulin. Alpha cells will secrete glucagon, and delta cells will secrete somatostatin. Okay, and this is what you can see here. This is the alpha cells, beta cells, and then delta cells over here. Is there anything important from here? Not too much. Okay. What's very important is you understand these two graphs. This graph is for the function of many medications that you might give for the patients. And then this one over here is for how insulin resistance happens. Okay. So what happens firstly? So what happens is this. Firstly, after you eat, you'll have hyperglycemia once you first eat a lot of glucose. So this glucose will go to the pancreas, to the beta cell, and go into the cell through GLUT2 transporters. Through glycolysis, TCA cycle, and beta oxidation, you'll have ATP. Now, what will this ATP do? It will inhibit the potassium channels. Potassium will usually move out of the cell. So this means that the positive charge will move out of the cell. So it'll cause the charge inside of the cell to become more negative, which is hyperpolarization. You inhibit this, potassium will stay in the cell, which means it's going to be more positive inside, which will cause depolarization. Okay? First year physiology from a long time ago. Okay? This depolarization will go all the way and cause opening of voltage-gated calcium channels, which will move calcium inside. Calcium is a trigger to remove, basically for granules full of insulin to be secreted, okay? So it gets secreted through exocytosis. This is how insulin is secreted. Insulin will go to three main parts of the body: liver, adipose tissue, and muscles. Okay, skeletal muscles. Now it binds to insulin receptors. Now, insulin receptors, something important about this is it's a tyrosine kinase receptor. This is the most crucial important thing about this whole slide. It's a tyrosine kinase receptor. It causes tyrosine autophosphorylation, and this will cause a bunch of steps to occur. PI3 kinase gets activated, AKT, whatever, okay? End result, GLUT4 gets transported into the membrane to cause glucose to enter the cell, and then you have increased glycogen synthesis, decreased lipolysis, increased lipogenesis and triglycerides synthesis, okay? And then and yeah, and what's it called? Basically to store everything, okay? That's the main function of insulin. The most important thing to remember is here. This is it, okay? Here you have tyrosine phosphorylation or tyrosine kinase, okay? If something goes wrong here, this will cause resistance, and I'll talk about this later. So, because this concept was very confusing to me when I first studied this last year, and I don't want you guys to be confused. Now, the most important pathology of the endocrine pancreas is diabetes. Okay, diabetes. Firstly, you need to understand what tests we do for diabetes. Diabetes is simply hyperglycemia that's more chronic, okay? Now, to diagnose diabetes, you have to have lab results or positive lab results. What are these lab results? The first one over here is fasting blood glucose levels, okay? The second one is 2-hour glucose after OGTT or random blood glucose. They have the same values, okay? The last one is HbA1c, which is very important lab result, and I'll explain why later. For the normal values of all of these, the first one is the fasting blood glucose levels. It has to be less than 100. For 2 hours, it has to be less than 140. And for HbA1c, it's less than 5.7%. Okay? Diabetes is if the fasting blood glucose is above 126 milligrams per deciliter. Random blood glucose or 2-hour glucose after OGTT is above 200. HbA1c is above 6.5. If it's between the normal and the cutoff range for diabetes, this is what we call pre-diabetic. Okay. Now you need to get one of these to diagnose diabetes. Okay. You need to get them at least 2 times, I believe. Okay, consecutively to be able to diagnose that this patient has diabetes. Okay. Now, if they're pre-diabetic, you just tell them, okay, come back later. However, you need to do lifestyle modifications. You need to lose weight. You need to do some, dieting, exercise, and so on to try to reduce the blood glucose levels. Okay. And they come back. If they're diabetic, you manage them. Lifestyle, pharmacologically, and insulin. Okay. We'll talk about this later. Now, for these patients, if you want to monitor their diabetes, which one of these 3 testing will you do? A1C. A1C will give you basically outline for you their past 3 months, okay? Because some people might, okay, I have an appointment in a week. I'm going to start taking all my medications, start exercising, try to reduce it. For HbA1c, it's not going to change anything, okay? Because it's reflective of the past 3 months, okay? Because of the basically the life cycle of the RBC, it spans 120 days and so on, okay? So that's why it's 3 months, okay? So yeah, this is the testing for diabetes and how to diagnose diabetes. Now, for diabetes, you have 2 types, type 1, type 2, and we'll talk about the specifics of both. However, usually with diabetes, they have polydipsia, polyuria, and polyphagia. Why do they have polyuria? Is that the glucose, they have so much glucose in the blood, hyperglycemia, that's going to go to the kidney, and it's going to exceed the reabsorption maximum of glucose. Okay, as usually all of glucose is reabsorbed in the kidney. However, it can exceed that, so glucose will be in the urine. So this will shift, cause an osmotic effect, and water will be secreted back into the lumen and will cause polyuria, a lot of urine. To compensate for a lot of urine, you have polydipsia. Okay, so that's that. They have weight loss sometimes as well. However, this is more apparent in type 1 diabetes. And then they might have in type 1 diabetes, DKA, I'll explain why. And then type 2 diabetes, they have a hyperosmolar hyperglycemic state in type 2. Now, the chronic complications, we'll talk about this more in detail later, okay? But just remember is that you have the effect of non-enzymatic glycation and you have the osmotic effect. And I'll talk about this later. What's important is to differentiate type 1 and type 2 diabetes, okay? Which is what we're going to do here. And I messed up the slide. As anyways, you have type 1 and type 2 diabetes. For type 1 diabetes, where is the defect? Okay, the defect is autoimmune, okay? For type 2, it's someone who is obese, later on comes to you with uh, insulin resistance, later on will come to you with exhaustion of the beta cells, which will cause the insulin deficiency and basically diabetes. In type 1 diabetes, it's autoimmune destruction of the beta cells, okay? And this presents very early in life, okay? So to manage these patients, you need to give them insulin. They are insulin dependent. They cannot live without insulin. For patients with type 2, in the beginning, you don't really need it, okay? In the beginning, you can firstly give lifestyle modification, oral anti-diabetic agents, and if this doesn't work, these two don't work, then you can give them insulin because later on they will have insulin deficiency, okay? Usually age-wise, type 1 diabetes presents early, below the age of 30. Type 2 is more of the older, someone obese later on presents with type 2 diabetes. Type 1 is less related to genetics than type 2, okay? Now, for type 1, it is more associated with the HLA-DR3 and TR-DR4. That's just something with genes and HLA system, but that's pretty much it. Now, very importantly is ketoacidosis. Now, in type 1 diabetes, that's very important, is they are insulin deficient, okay? They have destruction of beta cells. They don't have insulin. They don't have beta cells secreting insulin. So what they will have instead is unopposed glucagon. What will this glucagon do? It will cause lipolysis. Lipolysis will lead to ketogenesis. Ketones will be elevated in these patients, which will lead to ketoacidosis. And we'll talk about the symptoms later on. Now, why does it happen in type 1, not type 2? Is in type 2, you still have insulin. You still have insulin, okay? Now, another important thing about ketoacidosis is sometimes it's the first presenting sign of type 1 diabetes. They will present with ketoacidosis. And that's how you treat these patients with or diagnose these patients or find out that this patient has type 1 diabetes, okay? As I said, in type 1 diabetes, it is an autoimmune destruction of beta cells. So beta cells will decrease. However, in type 2, it's variable. In the beginning, it will be normal. Slowly over time, it will start to decrease, okay? As the beta cells start to fail and get replaced by amyloid, okay? Serum insulin from the very beginning in type 1 will be low because, again, it's a destruction of the islet of the beta cells. In type 2, in the very beginning, the insulin will be high to compensate for the insulin resistance. Slowly, it will decrease as the beta cells start to fail, okay? Now, classic signs of polyuria, polydipsia, polyphagia, weight loss is more common in type 1 because of the low insulin and sometimes in type 2. And we'll talk about the histology later. Tamam? It was supposed to be hidden and then show you the stuff, and I'll ask you guys, but I messed up with these slides. So anyways, the first patient here is, let's just say it's a 20-year-old patient, or no, let's say it's an 11-year-old patient who comes to you with lethargy, with polyuria, polydipsia, with confusion, altered mental status. What do you suspect this patient has? Type 1 diabetes. Okay, type 1 diabetes. Now, what do you see on histology for type 1 diabetes? What's the whole thing? It's autoimmune. Okay, so you'll have autoimmune destruction of the islet cells. So you'll have lymphocytic infiltrate. Good. Insulinitis. Okay. Now here, it's still around the lymphocytes. So this is what we call pre-insulinitis. Here it's peri, it's around. Here it's intra, and then here it's complete islet destruction. Okay, completely destroyed. Know these images. They'll probably give it to you as a total, all of it. But basically, you'll have islet destruction, insulinitis, because of the autoimmune destruction of the beta cells. Okay, this is type 1 diabetes. Now, type 2 diabetes. Okay, type 2 diabetes, these patients will have diabetes primarily due to insulin resistance. They have other comorbidities such as obesity, which is the main important one, or a family history of diabetes. Okay. Now, with these patients, why do they have insulin resistance? What happens at a biochemical level that causes insulin resistance? Okay. The most important thing is to remember the insulin receptor. Okay. This is the most important step. As I said, the insulin receptor is a tyrosine kinase receptor. That means it has tyrosine residues that autophosphorylates, okay? And it's a kinase, so it will phosphorate everything else after it, okay? Now, what happens in diabetes and with obesity is there's a lot of adipocytes. With this, you have certain types of fatty acids, okay? Or certain types of triglycerides. And this is what we call diacylglycerol, DAG, okay? Diacylglycerol. What this diacylglycerol will do is it will switch tyrosine to serine threonine. Okay. Instead of tyrosine phosphorylation, it becomes serine threonine phosphorylation or serine threonine kinase. This is much slower, much weaker than tyrosine. So what does this mean? Like, why is this important to us? Is insulin, when it binds with tyrosine kinase, it autophosphorates and phosphorates everything really fast. Okay. And you only need one insulin particle, for example. With insulin resistance or with serine threonine, this is much weaker. So you need much more insulin to activate this function of the kinase. Okay? That's why the most important player is DAG, which causes a serine threonine phosphorylation or kinase. Okay? This is how insulin resistance happens. Okay? And once this is much slower, everything else after it is slowed down. Okay? It won't happen as fast. This is why there is insulin resistance in type 2 diabetes. This is what causes it. Okay? And this is just to show, again, with obesity, you have a lot of adipocytes, which will increase amount of inflammatory adipokines, mainly. Free fatty acids, and we mentioned diacylglycerol is a very important triglyceride or diglyceride. And then you have inflammation, which will lead to insulin resistance. Initially, in insulin resistance, the beta cells will compensate by secreting much more insulin, way more insulin, okay? And this will control the glucose levels. Slowly over time, there will be beta cell failure and exhaustion, which will lead to decreased amount of insulin, and this causes diabetes later on, okay? That's pretty much insulin resistance. Now, slowly over time, these patients have this finding on histology. Firstly, what is the diagnosis and what is seen in this histology? Type 2 amyloid. Excellent. So this is type 2 diabetes, and it's basically where you have amyloid deposition into the beta cells or into the islets, okay? Which is all this pink amorphous material. This is type 2 diabetes, okay? Type 1 is insulin or beta cell destruction due to an autoimmune cause. Typically, these patients are very young, and typically these patients will have this, and they'll have an infection years ago that triggers this autoimmune destruction, okay? These patients, type 2 diabetics, obesity, cause insulin resistance, causes beta cell dysfunction, and then you have this, which is amyloid, okay, to replace it. So this is type 2 diabetes. No, there are three other forms of diabetes I want you to know. Two of them are here. One of them I'll talk about this in the repro section in obstetrics. But basically, you have MODY, okay, and then you have neonatal diabetes. In this one, what enzyme mutation is involved in this disease? This is the most important thing you need to remember. It's just what are the enzymes or genes involved. That's it. So in this one, in MODY, the enzyme is glucokinase. Excellent. Okay. How about neonatal diabetes? What genes are involved? A bunch of letters. Okay. Yeah. Okay. KCNJ11 and then ABCC8. Okay. A bunch of letters. Just memorize, like at least recognize it. If you have someone direct question neonatal diabetes case, or they give you these two in the question stem, know that's neonatal diabetes. However, most commonly you'll get this one, okay, for Moody. That's it. Okay. Now to end it off with diabetes complications and management. Okay. So for complications, you have firstly the very direct complications, which is the ketoacidosis and the hyperosmolar hyperglycemic state, which we'll talk about. Then you have the long-term effects. So with hyperglycemia, you have glycation, and with glycation, you have the HbA1c, which is glycated hemoglobin, and later on, it causes advanced glycated end product, which is AGEs. Okay. Now, what these AGEs will do, or advanced glycated end products, is two things. Is it goes to the basement membranes and it causes it to thicken and weaken. It's not a very leaky, however, it's thick, but leaky basement membrane. So this is one effect of the advanced glycated end products. The second thing is that this advanced glycated end products will bind to RAGEs, receptors of the, or receptors for the advanced glycated end products. Once it binds to these receptors, it causes fibroblasts and smooth muscle proliferation and so on, which will cause atherosclerosis, kidney disease, and so on. Okay? The next thing is sorbitol. So with glucose, it can be converted to sorbitol, okay? And with sorbitol, what we'll do is osmotic effect, okay? The most important thing, osmotic effect. So with sorbitol, if it accumulates in the eye, in the lens, it can form cataract, for example. That's a very important complication of diabetes, okay? So this is the pathways. Now, in terms of the complications, you have microvascular complications and macrovascular complications. Microvascular complications are three most important, and then macro is larger blood vessels, okay? Microvascular is going to be in the eye, which is what you guys tell me. What's in the eye, microvascular complication? Retinopathy. Kidney. Nephropathy. Nerves. Neuropathy. Good. Macrovascular, for example, stroke and MI. And MI is a very important cause of death in diabetes. Okay, probably the most common cause. Okay, is MI. Now we'll go over some complications. You can tell me what happened. This one, this patient has diabetes, and this is what you see on their skin examination. To give you a hint, this is in the neck and in the armpits. Good. Acanthosis nigricans, which is indicator of insulin resistance. And we talked about another sign or another reason why we see this in another disease in the GI tract. We mentioned this before. So another macrovascular complication, this one, is what? Because of the fibroblast proliferation, smooth muscle proliferation, atherosclerosis. Good. And this leads to MI or stroke. Or this next one, which is what does this patient have? To give you a hint, this is an arterial ulcer. And they complained before of intermittent claudication. Every time they walk, their legs start to hurt, and then when they rest, it goes away. Peripheral vascular disease, excellent. Okay. because of the atherosclerosis in the popliteal artery or the femoral artery or whatever. Okay. This patient has a complication. Retinopathy. Now, retinopathy in diabetes, it's a microvascular complication, and there's two types. There's proliferative and non-proliferative. If you see a lot of hemorrhages and a lot of proliferation, this is proliferative. Non-proliferative is something like this, okay? Way more blood vessels with a lot of hemorrhages, more than this, is proliferative, okay? How about this? Nephropathy, good. Do you guys remember what these lesions were called from renal? Yes, Kimmel-Wilson lesions, okay? KW lesions, good. And then you have glomerulosclerosis and diffuse glomerulosclerosis, so you can see, and replacement with fibrosis, which is the blue thing over here over time, okay? Or nephrosclerosis, okay? This image. Firstly, what are all three of these? What do we say that this patients with diabetes have more prone or are more prone to infections, okay? Generally. This first infection, what is this? This is in the oral cavity. Hint, you scrape it off and it goes away. Candida, good. So candidiasis. Okay, risk factor is diabetes, hyperglycemia, because they love glucose. Another thing is there's otitis externa, which is something called malignant otitis externa. Again, because of diabetes, it's a risk factor because of impaired immune function and because of the glucose. You know, organisms love glucose. Lastly, is this is a patient with a UTI, and you see that they have a fungal cystitis, okay? And that's pretty much it for these complications. Now for other complications, which is the hyperglycemic emergencies. There's two. Diabetic ketoacidosis and hyperosmolar hyperglycemic state. Diabetic ketoacidosis happens more in type 1. Again, insulin, if it's very low in type 1, or when they're in acute stress where they need a lot of insulin, what happens is they don't have it. So glucagon is unopposed. What will glucagon do is lipolysis, and with lipolysis, you have oxidation of these free fatty acids, and then you have increased ketones, okay? So what will these ketones do? Firstly, let's talk about its symptoms. They'll have delirium, psychosis, abdominal pain, dehydration, vomiting, okay? And they will have a fruity breath because of the acetone, okay? Now, important things are the changes in pH. In patients with ketoacidosis, will the pH be high or low? From the name, ketoacidosis, acid, low pH. Now, with ketoacidosis, it's metabolic acidosis. This metabolic acidosis, is it a high anion gap or low anion gap? High anion gap, because it's replaced with ketones. That's what's causing the anion gap, okay? Now, patients with metabolic acidosis, they compensate by respiratory alkalosis. Respiratory alkalosis, they will have hypoventilation or hyperventilation, if you think about it. You're trying to release CO2. Hyper. They start to hyperventilate, okay? Uh, yeah. So they'll start to hyperventilate. They'll release CO2 a lot. So with this patient, they will have low CO2 to compensate, okay? Because you're trying to reduce acid. CO2 is an acid. You try to reduce it, okay, to compensate. So that's pretty much it, okay? So you'll have hyperglycemia, uh, low bicarb, high anion gap, high urine blood ketone levels. Potassium could be elevated. Why? Is because they have acidosis. Acidosis is like a very common sign is they have acidosis with hyperkalemia. And yeah, that's pretty much it. Important thing is, how do you treat these patients with ketoacidosis? Okay. The treatment is firstly IV fluids. You need to establish IV fluids. You need to give IV insulin. What type of insulin can you give IV form? This is very high yield. Remember, insulin, you have rapidly acting, intermediate, short, and rapid. Sorry, long term. Again, repeat, long term or slow, intermediate, short acting, and then very rapid acting. The short one, what is it called? The insulin that you can give IV. Regular insulin, okay? Regular insulin. So you can give IV regular insulin. This is the only form that you give IV. And this is the form that you give in ketoacidosis. This is a very high yield. And potential questions can come from this, okay? And you give them potassium. Why? Is you have in acidosis, basically what happens with acidosis is you have increase in the serum potassium. However, intracellular potassium will be very low. When you give insulin, this will cause it to become even lower because, or sorry, when you give insulin, this will shift all the potassium from the blood into the cells. It will rapidly shift, which will cause hypokalemia, okay, when you give insulin. So what happens is you give it potassium to prevent the hypokalemia, okay? And you might also give glucose to prevent hypoglycemia from giving insulin, okay? Now, how do you know that this patient recovered from ketoacidosis? What is one lab value that will tell you that this patient's ketoacidosis is getting corrected? Do you guys know? Correction of what lab value? Ketones, give me more detail. What about ketones? Is it just the ketone levels? There's more specific. No. The most important sign that this patient is recovering or the acidosis is recovering, other than ketones, other than pH, is the anion gap. If the anion gap goes from high to low, or the correction of the anion gap is an indicator that this patient is recovering. Okay, one of the first signs. And the sign that you guys need to know because it was a question in one of your clinical lectures. Okay, and this might come in the exam. It's a very important sign, is the correction of the anion gap. Okay, in ketoacidosis, it's high. When you treat it, it should decrease the anion gap. Okay, so that's that. For hyperosmolar hyperglycemic state, the patient has hyperglycemia because of diabetes. Now, this patient is an elderly patient. Now, what happens with hyperglycemia is, as I said, polyuria. They start to urinate a lot because of the glucose in the urine. So with polyuria, they need to compensate by drinking a lot of fluids, okay, which is polydipsia, okay? Now, with elderly patients who cannot move, will they be able to go and drink water? No, okay? So they'll have something called a hyperosmolar hyperglycemic state, okay? The hyperosmolar is because you're urinating so much that your serum osmolality will go up. It'll be very concentrated. And because of this high concentration, you'll have hyperglycemia, which is often above 600 milligrams per deciliter, which is super high, okay? You'll have increased serum osmolarity as well, as again, because of you're urinating a lot, and this causes a very concentrated blood, okay? And this can progress to coma and death. The way you treat it, you IV fluids, IV insulin, same exact thing, okay? So that's pretty much it to try to correct this. The most important thing in this is dehydration. That's what causes it. So you need to hydrate the patient and everything should be better after that, okay? Now, last few slides on diabetes, which is diabetes management, which is a very important few lectures for you guys. Now, first line, in all patients with diabetes, the first thing you do, obviously for type 1 is completely different. They need insulin. However, you do lifestyle modifications, okay? They should know how to reduce, for example, their weight if they're type 2 diabetics, lifestyle modifications medications, weight loss, and so on, the therapies that they're going to be given, how they work, how to take their therapies, how do you take insulin, instruction on how to take insulin, and then the complications of these therapies. The most important complication overall from all of these therapies is hypoglycemia. They need to be able to recognize hypoglycemia, which is palpitations, for example, fatigue, and later on coma. They need to be able to recognize these symptoms and know these symptoms because they can manage it very easily, which is by just taking a bit of glucose and then making sure that they take their medications with adequate food, okay? And so on. Now, for type 1 diabetics, they need insulin. So all the medication that we're talking about for type 1 diabetes is insulin therapy. For type 2 diabetics, they'd have oral agents with metformin as the first line. We'll talk about them. And then you have injectables afterwards, okay? Now, for gestational diabetes, we'll talk about this later. And that's pretty much it, okay? Now, to talk about the different managements and the different, what's it called? Different types of insulin, okay? So firstly, insulin is the gold standard drug of choice for type 1 diabetics because common sense. They don't have insulin, so you replace insulin. Now, there are many preparations for insulin, and this is very important. This is a summary of the entire lecture. However, there are many details in your lecture. However, this is basically a summarized and important key things that you need to remember about them. So you'll have mainly four classes of insulin, okay? The first one is rapid acting. It has a very, very short half-life. The peak activity is around 1.5 to 2 hours, and it reaches its full, basically, its activity at around 5 hours. Okay, it's done. So that then you have to take another dose of it. The three drugs for rapid acting insulin is Lispro, Aspart, and Glulisine. What's important about rapid acting is they are the insulin of choice for postprandial hyperglycemia. So you instruct the patient to take it around the time that they're going to eat food. Okay, preferably right before and then eat. Okay, this is where they take it with the food. Okay, so if they're having, for example, 3 meals a day, they're going to take this injection 3 times a day. Okay, but it's usually not given alone. I'll explain that in a bit. Short-acting insulin, it's the next class, it's regular insulin. IV, regular insulin. It's the only one that can be given IV. This is very important. Now, its peak is around 3 hours, okay? And it reaches a maximum effect at 10 hours, okay? Where its effect dies down at 10 hours, okay? So that's regular insulin. The important thing, high yield thing about regular insulin is it's given IV. It can be given IV. It's used for the management of ketoacidosis. I've said this so many times. Please remember this fact, guys. Okay? Then you have intermediate, which is non-protein. I forgot the H. I keep forgetting the H. But anyways, NPH. Okay, intermediate acting insulin. It's intermediate acting. It reaches its maximum effect around 4.5 to 5 hours, and then it dies down around 15 hours later. So this is NPH. Okay. Then you have long acting. Long acting, you have 3: Detamir, Glargine, and Diglodic. The important thing about this is this can be given once a day, okay? Once a day, because it lasts for a very long time, the entire day, 18 hours. So you can give it in the morning once, and that's it, okay? Deglodic is very long acting, like it lasts the entire 24 hours, maybe, okay? Even longer sometimes. Why is this important to know these different preparations? Is they are given in combination, okay? So you instruct the patient that, okay, the combination that I'm going to give you is one of these long-acting plus this. What they do is they take this first one in the beginning of the day, and that's it. They don't have to take this till the next day. However, every time they eat, they take one of these, Lispro or Aspart or glutamine. They need to take this. This is basically how patients take it. Every patient who was diabetic with type 1 diabetes or on insulin medications, and the hospitals that I've ever seen are doing this combination. A long acting plus a rapid acting. Okay, rapid acting for postprandial control of glucose and long acting for the entire day. Okay, this achieves the best glycemic control. Okay, for patients with type 1 diabetes. Now, what is adverse effects? Very simple. Is you have hypoglycemia, makes sense. You're getting insulin, so you might have a hypoglycemia, lipodystrophy because of the injection, and they have hypersensitive reaction and weight gain because of the insulin, because of increased lipogenesis and so on. Okay. These are the insulin medications in a nutshell. Remember the key facts I mentioned. Rapid acting for postprandial. Regular insulin can be given IV, which is in ketoacidosis, very important treatment, and long acting is given once a day, and this is for the control of glucose throughout the day. Then you can give rapid acting every time you eat. Okay, all these drugs are given subcutaneously. Regular insulin can be given IV. Okay, so that's pretty much the insulin medications. Now for the anti-diabetic agents, oral anti-diabetic agents. The first line is metformin for any patients with type 2 diabetes. Now, you need to understand is some of these drugs can be given in type 2 or will be given in type 2 diabetes and will not be, you cannot give it in type 1 diabetes, okay? There's certain drugs you cannot give in type 1. However, there are certain drugs that you can give in type 1 diabetes. I don't mention this. The first classes of drugs we'll talk about is ones that increase sensitivity of insulin, okay? So this means that the tissues will be able to react to insulin more, okay? Very simple. So you have two drugs, metformin and pioglitazone, okay? Metformin, its mechanism of action is not fully understood. However, it inhibits mitochondrial glycerol 3-phosphate dehydrogenase, which will inhibit gluconeogenesis and the action of glucagon, okay? Now, what will this do is it will increase glycolysis or glycolysis and increases peripheral glucose uptake. It increases insulin sensitivity to a mechanism we don't really know. Now, because it increases insulin sensitivity, but not insulin secretion, will this cause hypoglycemia typically? Yes or no? It's not increasing the amount of insulin, however, it's increasing its sensitivity. No. So that's not a side effect of metformin, and this is a very important thing to remember about metformin. It does not cause hypoglycemia. The main important side effect, or the most common side effect, is GI upset. Okay, and that's what usually brings back the patient. Oh, I have GI upset. I can't take this medication anymore. Okay, the most important side effect is lactic acidosis, and this is important in patients with renal insufficiency. Okay, so that's it for metformin. Pioglitazone also increases insulin sensitivity by activating a important receptor on adipocytes, which is at PPAR gamma. So it increases insulin sensitivity and levels of adiponectin, which will regulate glucose metabolism, fatty acid storage. Basically, the gist of this is it will increase insulin sensitivity. That's pioglitazone. Remember that it activates PPAR gamma, okay? If you remember from CVP a long time ago, for the hyperlipidemia drugs, there's one drug that causes activation of PPAR alpha, and it causes cholesterol control. Very similar, PPAR gamma will increase insulin sensitivity, okay? So that's that. Its side effects, the one that I really want you to remember is edema, and in heart failure, you do not give pioglitazone in heart failure patients. So if you have a patient who has heart failure in the question stem, there's two drugs that you do not give in heart failure, this one and another one later on. Please do not pick pioglitazone. Or if it asks you what is a contraindication for pioglitazone, heart failure. Another thing is that increases the risk of fractures as well. Okay. Now, technically speaking, do you want to give these drugs to patients with type 1 diabetes? Typically, no, because they have normal insulin sensitivity. Their issue is that they don't have insulin. Okay. So typically you don't give them. Okay. You might give them to increase the action of insulin once you give it, but it's not really necessary at all. Okay. Now, the next class is secretagogues, okay? These will increase the insulin secretion from the beta cells. Now, you have sulfonylureas and meglitinides, okay? These drugs, what will they do? Is they will close the potassium channels that we spoke about a while ago. I'm not going to go all the way back. But anyways, it closes the potassium channel, which will cause depolarization, which will cause increased calcium influx, and this will cause insulin to be secreted. That's it, okay? So sulfonylureas, you have two generations. This is more tolerated, and it has less side effects, so that's all you need to know. You have glipizide and glyburide, okay? And then you have meglitinides, which is everything that ends with clinide, okay? Just remember, just memorize the ending, honestly, for a lot of these drugs. So anyways, you have the meglitinides. These will increase insulin secretion, okay? Now, because of increased insulin secretion, what's an important side effect? Well, what will happen to glucose? Hypoglycemia. Hypoglycemia is an important side effect in patients who are taking secretagogues, either sulfonylurea or meglitinides. Now, can you give these drugs to patients with type 1 diabetes? Yes or no? You guys tell me this one. Can you? Why? Why yes? So the answer here is no. Because in this case, the patients with type 1 diabetes, they don't have insulin to begin with to secrete because of beta cell destruction. So you can't really do anything with this one. So you don't give these drugs, okay? You don't give secretagogues, okay? So the answer is no. You don't give these drugs to patients with type 1 diabetes. This is given to patients with type 2 diabetes, okay? Now the last drugs here is you have ones that increase the glucose-mediated insulin secretion or glucose-induced insulin secretion. So what happens is if once you eat glucose, okay, or any carbohydrates, the glucose will cause increase in glucose like phosphate 1, which will basically go and increase the amount of insulin secretion and decrease glucagon, okay? Now, these GLP-1s can be inhibited by something called DPP-4. This DPP-4 will inhibit GLP, okay? This is normal physiology. So what we can do is we can give either GLP analogs or DPP-4 inhibitors. So GLP-1 analogs, okay? These drugs will increase the glucose-induced insulin secretion. Well, and what drugs are they? They are anything that ends with tide. Okay, that's how I memorize it. Tide. Okay. Now, another way to memorize it is what effects does it cause? It causes decreased gastric emptying and increased glucose-dependent insulin release, as we mentioned. So for decreased gastric emptying, what it will do is it will increase satiety and will cause weight loss, which is desired in these patients. Okay, so that's the Tide drugs, the GLP-1 analogs. Okay. The next one is DPP-4 inhibitors, which will cause increase in the GLP-1 because you won't be able to inhibit it, which is by the leptins, okay? Linagliptin, sitagliptin, and so on, okay? Way I memorize it, just memorize leptin, okay? So these will inhibit DPP-4, which will not be able to deactivate GLP-1, and then you'll have all the effects that you already mentioned. Now, what are these side effects for GLP-1 and for DPP-4? Because pancreatitis, important one to remember for GLP-1. And we have the satiety increase and weight loss, as we mentioned, why. And then you have respiratory and urinary infections with DPP-4 inhibitors. And this is something important to remember, okay? Very important to remember this and pancreatitis for GLP-1, okay? So that's pretty much it. Technically speaking, can you give this drug to patients with type 1 diabetes? Not really, because you won't be able to get this release. Okay, that's not usually given. Now, in these two drugs, okay, it's a bit different. Now, here you have decreased glucose absorption, two locations, one in the kidney and one in the GI. Okay, the GI is through alpha glucosidase inhibitors, which is by acarbose and miglitol. And basically, this will decrease the amount of glucose that's being absorbed by inhibiting the intestinal brush border alpha glucosidase. And this will decrease the amount of postprandial hyperglycemia. Now, because of glucose that's now, or carbohydrates that's now in the GI, this will cause diarrhea, GI bloating, and upset, and so on. Okay? Now, for SGLT2 inhibitors, this is in the kidneys, okay, in the proximal tubule. And these are the Flozin drugs, okay? Canagliflozin, dapagliflozin, and pagliflozin. These are in the kidneys. So once you inhibit SGLT2, this will decrease the amount of glucose that's being absorbed or reabsorbed in the kidney. So you'll have increased glucose in the tubules, which will be secreted and excreted in the urine. So with these patients, the amount of glucose in the urine would be up. So it'll cause an osmotic effect. So all you have is glucosuria, and you'll have increased urine in this case. However, the very good thing about these drugs is that it's very effective at removing glucose, okay? Now, very important is because you're urinating a lot more and glucose is going in the urine, it increases chances of UTIs, of infections, for example, candidiasis, because of glucose in the urine, which is a very, all bacteria love glucose. So UTI. Another thing is dehydration, because you will have a lot of urination, polyuria, because of the glucosuric effect, and this will cause dehydration with weight loss, okay? Again, straightforward. This is act in the kidney, so using caution in renal insufficiency, because in patients with renal insufficiency, the efficacy will be very low. Makes sense. And then lastly, you have something called amylin analogs, such as pramlintide, which will basically decrease glucagon and decrease gastric emptying, and that's pretty much it. Technically speaking, can you use the SGLT2 inhibitors and alpha glucosidase in type 1 diabetes? Yes, you can. Okay. Why? Is because it has no effect on insulin. Okay. This is completely just to remove glucose. Okay. So that's done with diabetes and its medications in detail, because these are medications that are very important. You'll get many questions on the side effects and its mechanisms, okay? And whether or not you can give it in type 1 diabetes or not. You guys have any questions for diabetes before we go to the last part of this crash course? Okay, tamam. Let's finish this off. Let's do the adrenal gland. Simple diseases, very straightforward. So let's go through them very quickly. Let's go. So the adrenal gland, you have two important structures in the adrenal gland: the cortex, which is outside, and medulla, which is very inside. Now, the cortex itself is divided into three layers, from superficial to deep. You have glomerulosa, fasciculata, and reticulosa, or reticularis. GFR, okay? Glomerulosa, fasciculata, reticularis. And then the medulla, which is the deepest structure, okay, and the inner structure. Now, for the hormones they secrete, glomerulosa secretes what main hormone? Aldosterone, excellent. Now, fasciculata, what's the main hormone that secretes? Cortisol, reticularis, androgens, excellent. Medulla, what does it secrete? Catecholamines, such as most commonly epinephrine, okay? So that's pretty much the secretions. In terms of histology, it's just to remember some of this. Glomerulosa look like the glomerulus from the kidney. That's why it's called glomerulosa, these structures. Then you have the fasciculata, which is the longest one, okay? And it's like tubes running down, okay? And then this is the reticularis, which is a very small portion, which is the darkest from the three. And then the medulla. The medulla is the darkest because it has a lot of brown areas because of increased vascularity, okay? Now, the main cells in the medulla are called chromaffin cells, okay? Chromaffin cells, the important things is how it stains, and I'll talk about this later in a tumor, okay, later. Now, for the axis of the adrenal gland, we talked about this a bit in the pituitary, but basically you have the hypothalamus, will secrete CRH, corticotropin releasing hormone, goes to pituitary, secretes ACTH. ACTH will go to the adrenal gland and secrete cortisol. Important thing to remember is cortisol will go back and inhibit ACTH and the hypothalamus, okay? As a feedback inhibition. Now, this will cause increase in cortisol. This axis, main point, is an increase of cortisol. So you could have something that's increasing ACTH from the pituitary gland, going to the adrenal gland and causing increased cortisol. Or you can have something over here that's causing increased cortisol, and the increased cortisol causes decreased ACTH through feedback inhibition. This is the main point of the like main axis, okay? Now, important thing to remember about this is something which is what's it called? Aldosterone. Aldosterone, the main stimulus of aldosterone is not ACTH. It is partially from ACTH. However, the main stimulus is angiotensin 2 and renin. Okay? So renin, angiotensin, aldosterone axis. This is something just to remember because in cases where you have Cushing's disease, they might not have aldosterone symptoms, okay, or hyperaldosteronism, because its main point is in renin, angiotensin, aldosterone controlling blood pressure. Now, in the thyroid, we mentioned the thyroid uptake using iodine. In the parathyroid, it's a MIB scan, MIBI scan. In the adrenals, it's MIBG scan, okay, which is very specific to the adrenal glands. Here you can see many different organs, such as the liver and so on. The most important thing to remember is it's more specific to the adrenal gland, and you can see more structures with it. That's an important thing about it, okay? And the important pathology to diagnose from an MIBG scan is pheochromocytoma. Okay, that is the most important pathology to see here. So if you see a patient with signs of pheochromocytoma and they show you an MIBG scan, go for pheo, okay? Now, the main pathology in the adrenal gland is Cushing's, okay, which is this. Now, signs and symptoms of Cushing's disease is we mentioned before, or Cushing syndrome. We mentioned before, moon phases, buffalo hump, osteoporosis, heart disease, obesity, what's it called, Donistria, moon phases, as we mentioned, poor skin, wound healing, skin ulcers, muscle weakness, and so on and so forth. Okay, we mentioned Cushing syndrome. We mentioned what lab investigations you guys want to do. Okay, let's review them quickly. The first screening methods you do is firstly low dose dexamethasone. Second thing is 24-hour urinary cortisol, and last thing is midnight salivary cortisol. If these lab values are elevated, low dose dexamethasone fails to suppress cortisol and ACTH or cortisol, then you have a diagnosis of Cushing syndrome. The next step is what, guys? What do you do next? ACTH. Tamam. So now you do the ACTH. Okay? If the ACTH is suppressed, then you have something which is ACTH independent. So either you have exogenous glucocorticoids or an adrenal tumor. What is the most common cause of Cushing syndrome? Most common cause. Exogenous steroids. Good. Okay? That's the most common cause. So when taking history, if they have, for example, autoimmune diseases, or let's just say, yeah, any autoimmune diseases or inflammatory states, and they're taking steroids and they have Cushing's, that's your reason. So when you're taking history, it says it in the history. Okay? The other type is adrenal tumor. Why adrenal tumor will have ACTH independent is because of the high cortisol causes feedback inhibition of ACTH. So that's why. So you do adrenal CT afterwards. Now, ACTH dependent Cushing syndrome is due to two things. Either pituitary adenoma, Cushing's disease, or second thing, which is ectopic ACTH. So you differentiate it by either high-dose dexamethasone or CRH, corticotropin releasing hormone stimulation test. So with high-dose dexamethasone, if it fails to suppress ACTH, it's ectopic. What is the most common location for ectopic ACTH? You guys know? Lungs. Excellent. Good. So this is exactly small cell carcinoma of the lung. Excellent. So ectopic ACTH secretion. If it suppresses ACTH and cortisol, then it's Cushing's disease from the pituitary gland. CRH stimulation, if it increases ACTH, this is Cushing's disease. If there's no change, this is ectopic. Okay. Now, if it's Cushing's disease, you do MRI of the pituitary to see the adenoma, straightforward. And then ectopic, you do CT of the chest, okay, to find the tumor, okay? Now, important thing about Cushing's is the changes that happens to the adrenal gland in all of these causes. Now, if you have a patient that's taking exogenous cortisone, the ACTH will be low. So what will happen to both adrenal gland? Atrophy. Excellent. Good. Atrophy. If they have Cushing's disease, where you have high ACTH, what will happen to both adrenal glands? High ACTH. Hyperplasia. Good. Same thing with ectopic. Now, what happens if you have a right-sided adrenocortical adenoma secreting ACTH? What will happen to the left? Good. Atrophy of the uninvolved gland. Good. Excellent. This is super important to remember. So this change over here, this is the normal. This is what happened to this adrenal gland. What happened to it? No, this is the normal. This is the abnormal. What happened to it? Hyperplasia. Got bigger. Okay. So you have diffuse cortical hyperplasia. You see this yellow bit over here? That's the cortex. This inner one is the medulla. The cortex got huge, really big. Okay. Hyperplasia. So that's that. Now, how about this patient? What's your diagnosis? Very simple. This is the adrenal gland. It's in the cortex. Adenoma, good. If you remember from radiology last year, is the tumor is hypodense. Why is it a bit hypodense? Is because of fat. Okay, and you can see clearly some fat droplets in histology. Okay, because it's secreting steroids, fat. Okay, so this is adrenocortical adenoma. Tamam. How do you treat adrenocortical adenoma? Either it's usually adrenalectomy. You remove this tumor, okay? But make sure to replace steroids with steroids after it because you want to prevent a crisis afterwards, okay? How about this patient? Atypia, very bad looking tumor, bloody, has weight loss, carcinoma, good, okay? What genetic syndromes, two of them, is associated with? Lee-Fraumeni, good, one more. Beckwith-Weidman syndrome, okay? Lee-Fraumeni, just so you guys know, it's a genetic disease with a P53 mutation. It basically causes a lot of sarcomas, adrenocortical carcinoma, breast cancer, and leukemias. Okay, so it's a syndrome of many, many, many tumors. Beckwith-Weidman is another tumor syndrome, okay, but it's very, very rare, okay? So that's adrenocortical carcinoma and adrenal adenomas, okay? Now, the other thing is hyperaldosteronism. You have primary and secondary. Primary is because of one second, guys. I'm just gonna connect my laptop. 1 second. Okay. Hyperaldosteronism, you have two types, primary and secondary hyperaldosteronism. So primary hyperaldosteronism is due to something from the adrenal cortex that's secreting a lot of aldosterone. So typically you'll have low renin and high aldosterone. That's typical. Secondary hyperaldosteronism is the opposite, okay? You'll have high renin and high aldosterone. This is because of something that's causing high renin, such as renal artery stenosis, okay? Now, for the primary hyperaldosteronism, the most common is idiopathic, or something we also call bilateral adrenal hyperplasia or congenital adrenal hyperplasia, okay? So this is bilateral, and it's the most common type. Then we have adenoma, which is the second most common, and it's a tumor basically of that's secreting a lot of aldosterone, and this is unilateral, and this is the second most common. Either way, this causes high aldosterone. How does high aldosterone present with? It presents with hypertension, hypernatremia, and hypokalemia. Okay, so this is the triad in hyperaldosteronism. Okay, that's pretty much that. Now, in this case, in this patient, they have hypertension, hypernatremia, and hypokalemia. You do renin-aldosterone ratio. It is high aldosterone, low renin. What's your diagnosis? You guys know. Aldosterone adenoma, what do we call that? What is an aldosterone secreting Conn syndrome? Good. What is seen over here? What are these small cells called? Spironolactone bodies. Excellent. Good. This is very important. Okay. That's pretty much that. Now, for this, for the algorithm for diagnosis of hyperaldosteronism, if you have a patient who has hypertension, hypernatremia, hypokalemia, you do first thing is measure the renin aldosterone ratio, okay, the aldosterone renin ratio. This should be elevated in patients with primary hyperaldosteronism. However, this is the first test. You need to confirm it. You confirm it with saline infusion test or saline suppression test, okay? Now, in saline suppression tests, usually it will decrease this ratio. However, in these patients, aldosterone will not be suppressed. So this is the confirmatory test for patients with hyperaldosteronism. If they have secondary hyperaldosteronism, they will have a ratio, which is the aldosterone to renin ratio will be high, okay? Or sorry, the aldosterone and renin will both be high because the renins were causing the high aldosterone. And this is seen usually in renal artery stenosis. So for primary hyperaldosteronism, you do an adrenal CT. An adrenal CT, what you will see is either a tumor or something that's hyperplasia with both of them, okay? Now, another way you can see that these patients have hyperaldosteronism is something called adrenal venous sampling. Now, here's something important to remember, is adrenalectomy. Adrenalectomy is surgical removal of the adrenal glands, and this is primarily used for Conn syndrome, for adrenal cortical adenomas, and so on. Now, in the cases of Conn syndrome and hyperaldosteronism, is you consider surgery for those who are under the age of 35 to 40. You usually go for it, okay? And if it indicates malignancy and you see a tumor, you go for it. If they are a poor surgical candidate, you might go for aldosterone receptor antagonist. Most common drug is spironolactone. Okay, so if they're over the age of 35, or like they won't be able to handle the surgery, then you go for this. And this is also preferred in patients with bilateral adrenal hyperplasia causing the hyperaldosteronism. Okay. If they have bilateral hypersecretion because of from the adrenal venous sampling, then you go for this, which is because of the hyperplasia, bilateral hyperplasia. If they have unilateral, you just remove the Conn syndrome or the thing that's causing the hyperaldosteronism from one of the adrenal glands. Okay, so this is the algorithm for hyperaldosteronism and its management. Now, the last few topics in this whole crash course is steroidogenesis. Okay, very important thing is to remember three enzymes. First thing is to remember the key steps. Cholesterol will go to the mitochondria through star. This is the rate limiting step. Okay, remember this. The rate limiting step is to bring the cortisol from the cytoplasm into the mitochondria through star. Then it gets converted to progesterone and so on. It goes through two pathways. Okay, the two pathways it goes through is either through aldosterone or through this step, which is through the 17 alpha hydroxylation to glucocorticoids. Now, the step where it goes through aldosterone, it goes through two steps, 21 hydroxylation and 11 beta hydroxylation. You give corticosteroid and then aldosterone. Again, the biggest stimulus is angiotensin 2. If it goes through 17 alpha hydroxylation, it gets converted to cortisol and androgen pathways. For cortisol, the 17 hydroxyprogesterone gets converted to 11 deoxycortisol through 21 hydroxylation, and then to cortisol through 11 beta hydroxylation. To androgens is through the 1720 lyase, and then it goes to androgens. The most important enzymes are these, A, B, and C. 17 alpha hydroxylase, 21 hydroxylation, and 11 beta hydroxylation. Let's talk about this very quickly. First one is 17 alpha hydroxylase. Let's just knock this one out, okay? For 17 alpha hydroxylase, there will be the pathways to cortisol and androgens will be absent. It will all go to mineralocorticoids, to aldosterone. So, what will this patient have? High aldosterone, low cortisol, and low androgens. So for high aldosterone, we mentioned, they will have hypertension, hypernatremia, hypokalemia. That's going to be given to you guys. Now, they won't have cortisol, so they might have hypotension and signs of Addison syndrome, Addison's disease, such as, for example, hyperpigmentation, okay? Because of high ACTH, that's causing the hyperplasia because of the low cortisol. Lastly, and in males, they won't have androgens being secreted from the adrenal glands, so they will have ambiguous genitalia, okay? Because the androgens will be missing. In females, they will just have absent secondary characteristics such as hair and some breast development, okay? But that's pretty much it. Now let's knock out 21 hydroxylation, okay? So for 21 hydroxylation, let's just move this. For 21 hydroxylation, it is the most common type, and here's what happens. The pathways to cortisol and to aldosterone will be broken. It won't have that pathway anymore. So what will happen is all of the cholesterol will go into the androgen pathway. Okay, so now no aldosterone at all. What will this do? Hypotension, hyponatremia, and hyperkalemia. Okay, so that's what happens with low aldosterone. Now with low cortisol, again, bilateral hyperplasia and hyperpigmentation with signs of Addison's disease. Okay, now what will high androgens do? For females, it will cause ambiguous genitalia. Okay, for males, it will cause precocious puberty. Okay, so that's pretty much for 21 hydroxylation. Again, the most common. How do you diagnose, or what is a very important sign of this on lab investigations? It is elevated 17 hydroxyprogesterone. Remember this, please. Okay, for a lot of lectures, 17 hydroxyprogesterone will be elevated. Okay, in 21 hydroxylation deficiency or hydroxylase deficiency. Now the last one is 11 beta hydroxylation, which will basically decrease the amount of aldosterone, decrease cortisol, same exact thing, and then androgens will go to androgens. However, in 11 beta hydroxylation, you will have 11 deoxycorticosterone, which is a weak mineralocorticoid. In this case, this will act as a mineralocorticoid, so you won't have the signs of aldosterone deficiency. However, cortisol will still be low, so you'll have Cushing syndrome, ACTH, and so on. That's how you tell the difference between. And we basically talked about it here, and basically that's pretty much it for this slide, okay? Now, this patient over here is dehydrated, has abdominal pain, fever, hypoglycemia, hyponatremia, hyperkalemia, hypotension, as we mentioned, weight loss, anorexia, and hyperpigmentation, as you can see here, and in the creases, okay? What do they have? Addison's disease. Good. Low cortisol. In this case, because of the hyponatremia, hyperkalemia, and so on, they might have adrenal hyperplasia, as we mentioned, the types. Okay. Simple as how you manage these patients is you replace it. You replace the hormones. You give cortisol through glucocorticoids, and you give aldosterone through fludrocortisone. Okay, which replaces both of these uh, hormones, and that's pretty much it. Now, you have a patient who has Addison syndrome. However, this patient is a 20-year-old male who lives in a college dorm, presents to you with Addison syndrome, adrenal crisis, and petechiae in the legs. What do they have? Waterhouse-Friderichsen syndrome, which is hemorrhage of the adrenal glands. What organism causes it? Neisseria gonorrhea. Good. Okay, and it's typically how I described it. Close quarters, college student, and it will present with all of this. Okay. Now, for pharmacology, you can do multiple different things. Firstly, we want to try to inhibit glucocorticoid synthesis, and I think, yeah, I put it here. So you want to try to inhibit glucocorticoid synthesis, which is the first step if they have Cushing's syndrome, for example, which is through synthesis inhibition through ketoconazole, which will inhibit the 17-alpha hydroxylase and the 1720 lyase, which will inhibit or decrease the amount of glucocorticoids. And then you have also mifepristone, which will also inhibit the glucocorticoid receptor. Okay, so cortisol won't be able to bind to its own receptor. Now you have other drugs such as mitotane and so on, which will inhibit, for example, the beginning steps, okay, of desmolase and so on. Now, mineralocorticoid antagonist is spironolactone. It inhibits the aldosterone receptor, so aldosterone won't be able to cause its effect. And this is mostly the drug of choice if you have bilateral adrenal hyperplasia that has high aldosterone, okay, to try to reduce it. Now, if you're trying to replace the hormones, you have glucocorticoids through prednisone and fludrocortisone. Now, important thing about the glucocorticoids is you have many different types, okay? So uh, you have, for example, the ones used in asthma, the ones that are anti-inflammatory, such as adenoside and so on, prednisolone. You know, just slightly about it. It's not that many details. Just know glucocorticoids and its side effects. The side effect is Cushing's syndrome, okay? Just remember Cushing's. They'll have Cushingoid features, osteoporosis, and so on. This is the most important side effects of this of glucocorticoids. Okay. Now you have this one patient who has episodic hypertension, palpitations, sweating a lot. What do they have? Pheochromocytoma. Perfect. Good. This is again an MIBG scan of the adrenal gland, and you see pheochromocytoma. You do histology or biopsy, you remove firstly, you do adrenalectomy and you remove the adrenal gland, and you can see it's in the adrenal medulla, okay, which is this brown hemorrhagic part which is inside. The yellow is the cortex. And then you do histology. Firstly, diagnosis is pheochromocytoma, as you guys mentioned. Now, histology, you'll see these spindle cells, but very importantly is this thing in the middle. Do you guys know what that thing in the middle is? Okay. That thing in the middle is Zellballen nests. Remember that term, okay? Now, how do you manage patients with pheochromocytoma? Is surgery. However, there's a step you do before the surgery. You need to give them alpha blocker, then beta blocker, and do the surgery. Okay? The reason why you give alpha before beta is if you give beta before alpha, the beta receptors will be blocked. All the catecholamines, epinephrine will bind to alpha, which will cause hypertensive emergency. Okay? So you give alpha blockers, such as phenoxybenzamine, and then you give beta blockers after it. Okay? Now, if this patient was uncontrolled and then you come and do another MIBG scan and you see this, what happened to this patient? What happened to the pheochromocytoma? Metastasized. Good. Okay, perfect. Now you have this very young patient who presents to you with similar to Theo, but less, I'll just say, but catecholamine excess, and they have weight loss, psychiatric or neural symptoms, neuroblastoma. Good. So neuroblastoma, you diagnose it, you do biopsy and resection, and you see this. Do you know what this is called? This first image, very important image, very high yield. These are called Homer-Wright rosettes. Okay. Now, neuroblastoma is very malignant and very metastatic. Okay. So hence why it's everywhere. Here, it can differentiate into a ganglioneuroblastoma and then a ganglionoma, which is more benign. Okay. Now, important thing about both of these, pheo and neuroblastoma, more importantly in pheo, is in pheochromocytoma, you can do staining, and the staining that you do is for chromogranin and synaptophysin, okay, which will be positive. And you have also S100, which will be positive, okay? That's pretty much that. Important thing about neuroblastoma as well is it's associated with a specific gene, which is NMEC, okay? And that's something just small to remember. Last two slides, as you have Men's syndrome. Men's syndrome are autosomal dominant diseases or syndromes characterized by multiple endocrine neoplasias, many cancers. Okay, so you have three types, and we mentioned this slightly in GI: Men 1, Men 2A, Men 2B. Men 1 is a three P's. Okay, pituitary tumor, which is usually prolactinoma, pancreatic endocrine tumors, which we talked about in GI, insulinoma, and so on, and then parathyroid adenomas. Okay, parathyroid adenomas. Now, this is a mutation in MEN1 gene, okay? Very important. MEN2A, MEN2B is associated with mutations in the RET proto-oncogene, okay? MEN2A is parathyroid hyperplasia, all four glands, medullary thyroid carcinoma, and pheo, okay? MEN2B has pheo and medullary thyroid carcinoma with one M, which is the mucosal neuromas. And then you can see marphonoid habitus and so on. Okay, and this is an example of a neuroma. Okay, and the mucosa, which is the tongue. Okay. Now, a way to remember this is MEN1 has three P's, MEN2A has two P's with one M, which is the medullary thyroid carcinoma, and MEN2B has one P and two M's. Okay. So a way to remember how to manage this as well is very simple. Management is very, very simple. You firstly treat all of this underlying cause. Here, if you have a patient who was recently just diagnosed with pheochromocytoma, let's say, and then you do genetic analysis and they have RET positive mutation, what do you do for this patient prophylactically? They have pheochromocytoma with RET positive. What do you need to do? This is a very high yield concept. Is even though they might not have any of the other signs of MEN 2A, they have the gene. So they have 100% chance of developing medullary thyroid carcinoma. So you do prophylactic thyroidectomy. You remove the thyroid. Okay. If you have a patient with RET positive, you also check for the family and check if they have RET positive. If they have RET positive, you also remove their thyroids. Okay. Because they have 100% chance of developing medullary thyroid carcinoma. And then you treat the other causes that we mentioned before. Okay. Last slide of this crash course, and this is on autoimmune polyglandular syndromes. Basically, they are the opposite of men. Men causes hyperfunctioning or neoplasms. In this one, it's hypo, okay? Everything is hypo. So you have hypoparathyroidism, Addison's disease, type 1 diabetes, autoimmune thyroid disease, and so on, okay? The most important one in high yield is a autoimmune polyglandular syndrome 1, which is autosomal recessive in the AIR gene, and it has mucocutaneous candidiasis. Okay, this is very important. You will get a sign, you'll get a picture of either someone with tongue candidiasis or anywhere else. Okay, this is a very important concept. With hypoparathyroidisms and Addison's disease, diagnostic antibodies is anti-interferon for APS1. APS2 is less common, and they typically have type 1 diabetes with Addison's and autoimmune thyroid disease. Okay, but just remember Candida and APS1. Okay, and we are done with the endocrine crash course. Do you guys have any questions? Anytime. Okay. Inshallah, for the next time, we'll go over all of repro, which inshallah should be a more straightforward one because the pathologies are very interlinked and related. So I can summarize it much more quickly. Okay. So yeah, good luck, guys.